topics that we are going to highlight today. We are going to talk about the life course immunizations and the age-related changes in the immune system and the concept of immune sensitivity and the burden of infectious disease in patients with comorbidities, and we are going to identify those populations at risk. Of aging populations and strategies to maintain a healthy immune system in aging. Saudi National Immunization Program for Elderly is another area where we are going to focus today. An unmet need and challenge of implementing adult vaccination, and this will highlight our clinical challenge that we encounter in our day-to-day practice. So we will start by the first question, which will be given to Dr. Majid. Dr. Majid, what is the life course vaccinations? This is a very commonly asked question, and it needs a lot of elaboration. So please, if you can tell us a little bit about it.
Thank you very much for getting me today, JSK, and also for invitations for the Saudi Society of the Family and Community Medicine. And thank you for all the attending today for our session, and for also those listening to the online the platform. So as a trend now, just to increase the people how to be consider the immunization as the cornerstone of the health system now, we focus to include all the different age group. In history, we've known the immunization specific for age group, which is for the infants, I would say, and children before the age of the school time. However, now with studies that demonstrate the effectiveness of vaccine for a specific disease, and also the effects of the protection level for some vaccines, so the need of boosting, this is lead to the sum of recommendation of public health specialists to introduce some vaccine to a specific group. For example, vaccines not only for infants, we have also, as I mentioned, for the children. Now we are focusing, especially in the kingdom, that we have a specific program for the adolescents, for the adults, and for the elderly. And this is actually depends on basically on the age, grouping, or immunocompromised status, or even immunocompetent, but they have a chronic disease. So based on these things, we have to provide each group of those people a specific vaccine to boost their immunity against of any risk. And again, once we have this program, we expect, as a public health expertise, to have improved for the KPIs for the health of people. We expect one of the effects that will increase the herd immunity. I think is one of the successful programs in the kingdom. For example, we reached to a level to eradicate some of the disease, and we are fighting to eradicate some of the disease by some of the programs in parallel to the WHO vision. So all these will improve the KPIs for the prevention of the vaccine-preventable disease. As you know, the increase of the globalizations, people travel everywhere, they could expose for different strains, different people with different risks. People could, have a breakfast today in a specific place and have a dinner in another place, far away from here. So these traveling definitely will have lots of risk, and one of these exposed to the infection. Again, specific age, I would say, in addition to the age group, we have a specific characteristic of occupational groups. I mean, such as the military when deployed for a specific area, and for healthcare workers when exposed to the blood-borne disease, so they are risky, for example, for hepatitis B, so they have to be vaccinated for hepatitis B. When they are providing a service for specific places, for mass gathering, for example, so they have to be protected for flu, for meningococcal disease, etc. So all these play an important role to give an important perspective to the importance of such a program. And they found in the studies also that to improve the antibiotic stewardship program in a way that we will reduce the resistance against of the for the bacterial infection, for example, as we can have an example for the pneumococcal vaccines that affect definitely to the pneumonia incidence. So basically, we will lead to decrease the risk of the admission and any mortality morbidity related to such infection. So all these, that explain the importance and what is the life course, I would say, immunization program.
Okay, thank you so much, Dr. Majid. And I think it's very obvious that there is throughout the spectrum of life, there is, vaccination should cover all the age groups regardless. So there was a common belief that vaccination just only confined to the childhood immunizations rather than the adult. And this is in fact one of the misconceptions which has been worked, better now, and there is a good perception by majority of people, but still we are lacking behind the proper perceptions of having a proactive move, by those people to have the vaccinations. Okay. So, Dr. Asim, why does changing demographics require a new vaccination strategies?
Bismillah ar-Rahman ar-Rahim. First of all, I'd like to thank the organizing committee and GSK company for this invitation. Special thank for my professor, Prof. Ashraf, for this invitation. He is the leader for the medical education. It's an honor to be with you and with my colleague here, the experts. Well, changing the demographics actually impact the vaccine strategies by different ways, and for several reasons. The main reason is the age distribution in the community. So, and the fact that there is specific diseases that might hit the age group, like during childhood and in elderly. For example, in elderly, we have more common diseases that happen at this age, shingles, pneumonia. The other thing is that even with specific disease, like patients with advanced dementia, advanced Alzheimer's disease. So the most common cause for death in advanced dementia is pneumonia. So we can prevent that. So age distribution is one factor. The other factor is the immune variability. The immune variability, as we know, once we age, our immune system gets weaker and age with us. So that's a different thing. The other thing is that the demographic, the geographic changes. When we think about urban area versus the rural area, the population density is different, and the spread of the disease is different, infectious disease is different. So our strategy should be built on those kind of factors to give the patients and the community better medical services. That's open up a discussion about the population health management. Vaccine is one part of that. The other factor is the cultural changes and the mindset of the population. And my colleague will talk about it later on. But honestly, the cultural acceptance for vaccine is different. And it changes by time. Before COVID is totally different after COVID. Now in my practice, I'm facing a challenge convincing my patients to have flu vaccine. And you would imagine, before COVID, it was easy, then the patient will be easy to have the flu vaccine. But now, our strategy needs to change. We need to have more awareness campaign, more discussion, giving the patient time to talk. So this is, I would say generally speaking, but this is I will discuss those numbers. In 1900s, society had a relatively high proportion of children and younger population. And that time, the focus was on childhood immunization. However, in 2020, we have 700 million, more than 700 million older adults above 60. And this number would increase in 2050 to double. So our consideration, our strategy needs to move to the infectious disease and the prevention of infectious disease at that age group. When we talk about, we have an example here about the pertussis, the burden of disease.
Excuse me. Can you come and see here? الصورة راحت.
Sorry for the technical problems, but when we talk about the burden of disease, about one of the, nice picture by the way, about one of the diseases like pertussis, the pointer, which one? No, the pointer. So about pertussis is shifting from children to older age group, as shown by data from the Australian study. As we compare less than 18 years old, in 1993, for example, it was about 63.2%. At the same time, we have it for those patients aged from 18 to 64, it was 32.9. And as we see, and the percentage of the pertussis cases in older adults above 65 years also increased. And the pertussis infection have increased risk of hospitalization compared with younger adults. As we see, the incidences will be similar. However, at the age of above 65 and more, 75 years old, there is an increase, huge increase in hospitalization, which is the thing that would make a huge burden on the health system and the health expenses. So the other question is about why do we need to vaccinate older adults? Do you guys agree about it or not? What do you think? So older adults, as I mentioned, we will have people that would live more. Moving to urban area is getting more and more. Civilization, better home, better healthcare, and better nutrition, education, that would make us live longer, inshallah, in the upcoming years. This is at the level of, moving to another places, having better education, but what about at the cellular level, immune system? Our immune system, as I mentioned earlier, once we get older, our immune system gets old as well. And the response to the infection, it might be not that good like when we are younger. And this is normal physiology. As we see here in the graph, with the newborn, the immune system, it's immature, and the risk of infection will be high. During the childhood and adulthood, our immune system now have a lot of experience with a lot of viruses, having antibodies. Our immune system will be mature enough to fight. However, the decrease will go down, and there's a decrease down and down and down till once we get older, our immune system will be weaker and the risk of infection will be higher. So what is behind it? Immunogenesis it's something that happened. It's a physiological changes that happened. In this graph, it's kind of complicated. I'll try to make it much easier. The hematopoietic stem cell, which is the multipotent cell, differentiate normally to the common lymphocytic progenitors that would give us the B cells, and we have the common myeloid progenitors, which will give us the natural killer cell and neutrophils. At the thymus level, the early T cell progenitor will give us the double negative and the positive, double positive cells. Then it differentiates to CD4 and CD8. So this is normally happening during our life. However, once we get older, at the genetic level, there is decrease in the transcription and deletion of some genes that would affect the number of those cells and the differentiation of those cells. Then the number will be low and the functionality of those cells will be affected as well. Then we are at that level, we will have a weak immune response.
Well said, Dr. Asim. Thank you so much. And I think here I would like to mention that we have to anticipate the future, because we have certain drivers in our healthcare system that mandated the decision makers to make the paradigm shift in our healthcare system to transform to be more efficient and to utilize all the resources and to capture the risk that our population is at risk in the future. One of it is our population in the kingdom, they are going to be doubled by the year 2050. The elderly populations, as we speak today, we have been identifying the kingdom to be a young population's community. Why? Because more than 60% of our population is below the age of 35 or 40. But what will happen in 2020, 2050? The geriatric populations of 65 years and above, they are going to increase from 4.2 to 9.6, so they're going to double. And and there is one of the parameters that has been put as an indicator for Ministry of Health as a KPI to perform better for our healthcare system is to enhance the life expectancy of our population from 78 years to 81 years by the year 2050. Moreover, the high epidemicity of certain disease, especially chronic disease, Saudi Arabia has been identified to be one of the top countries in the high prevalence of diabetes, dyslipidemia, obesity, smoking, and so forth. So it means that we are going to live longer, we are going to be elderly populations, and we will carry along with us all the immune suppressing, disease that will keep us at risk of having this kind of decreased immunity in the future. So I think this is a very important perspective that we have to look in the future, and we have to exert our resources and our effort in order to identify those populations at risk and to enable them to lead a quality of life without any getting into this kind of cost. Thank you. So, Dr. Sana, this is another terminology that we are hearing it very frequently, which is immunogenesis. How does it affect the immune system? So this is a new terminology that we have to use, and we have to understand exactly what does it mean, so we can use it as a medical terminology to express what does it mean.
First of all, thank you, Dr. Ashraf. Thank you for invitations. Thank you, GSK, for inviting me for this afternoon seminar. I hope it will be enjoyable and really nice and interesting. I wanted to use our local language here. Please let me know if there is non-Arabic speakers so that we can translate to them. It's make me more comfortable. What is immunosenescence and how does it affect the immune systems? ما معناه ببساطة الجهاز المناعي يتقدم في السن. جهازنا المناعي وصل لمرحلة إنه صار ضعيف. Fact, حقيقة. We have to accept it whether we like it or not. وهذا التقدم في السن بسبب عدة عوامل، قد تكون عوامل بيولوجية، عوامل فسيولوجية، عوامل في نمط الحياة نفسها. شغلات إحنا بنعملها بتخلي الإميون المناعي يضعف، وشغلات زي ما قال الدكتور natural. Several mechanisms can contribute to age-related decline in immunities. Epigenetic changes. I love that word because I studied many times when I was really studying lifestyle medicines. Our gene is not our destiny, our lifestyles. We are the one determining to which direction we need to go. Inflammations, chronic low stage inflammations. البعض يتساءل إيش شغلة الانفلاميشن في هذا الموضوع. خلال حياتنا بنتعرض لكثير من الأدوية، الأشعة، العوامل البيئية بتخلينا على طول في مستوى معين إن إحنا بناخذ شغلات على طول. فهذا الشيء بيخلينا في وضع إنه على طول في low grade of inflammation in our bodies. الجسم ما يقدر يتعامل معاه. free radicals موجودة على طول معانا في أجسامنا. The last thing, which is our part that we need to play on it, the immune exhaustion. Our immune system get fatigued. الجهاز المناعي تعب ضعف. Resilience is the capacity of the body to resist the functional declines. We need to rebuild our immune system, increase its capability to نبى نرفع قدرته مرة أخرى، نبى نقوي هذا الجيش اللي موجود عندنا to fight infections against. And again, there is different method to increase the capability or resilience of our immune systems. Vaccine response can be impaired with age, as we can see. We're not going to ما حندخل في البايوكيمستري والفسيولوجي because here we need to enhance and secure health. وظيفتنا هي حماية الصحة ومتابعة حماية الصحة.
So, Dr. Hasana, how we can overcome the lower vaccine response in elderly patients?
This is what I'm going to talk on it.
Yes, go ahead.
Can I go back on this one?
Yeah, go ahead.
Right. To overcome that lower vaccine response in elderly, we have different mechanisms. Let us to imagine, we'll imagine together. أنا الآن عندي شخص كبير في السن ومناعته منخفضة. تتوقعوا إيش ممكن أعمل له عشان أزود مناعته؟ اللي إحنا بنعمله في البي اس سي ولا في المجتمعات الصحية عندنا. I didn't hear you. في أحد قال هنا لايف ستايل. اوكي it could help، بس هل تتوقع هي واحدة من الطرق اللي أكيد حترفع مناعته لو هو ماشي على اللايف ستايل صحي؟ طيب اللي احنا لما جانا كورونا كوفيد، ايش اللي حصل في الكوفيد؟ ما اعرف سمعتوا عن مصطلح اسمه الهيرد اميونيتي او مناعة القطيع؟ لما واحد شخص ينعدي والباقيين ينعدوا ايش يحصل لهم؟ ايش يحصل لهم؟ مناعة القطيع وذر بشكل مباشر او غير مباشر الكل حيصير اميونز. هذه طريقة. ايش الطريقة الاخرى اللي ممكن احسن فيها مناعة؟ غالبا الجرعات التطعيمات في الاطفال تفرق عن الكبار، انه انا ازيد الانتيجينيسيتي، ازيد جرعه الانتيجين اللي موجوده في جرعات الكبار عشان الاقي تو انهانس الاميون سيستم، ابغى الريسبونس يكون اقوى. هذه طريقه انكريزنج ذا انتيجينيسيتي. ايش الطريقه الثالثه اللي ممكن ازود فيها او اقوي الجهاز المناعي؟ ايش اعمل؟ ان انا احط نظام الادجفنت سيستم، وهذا اللي معمول في الريكامبينت هيربيز زوستر فاكسينز. صراحه فاكسين جدا فعال وجميل، حاطين فيه انه انا اخذ البروتين حق الفيروس واحط جنبه ماده مساعده تو انهانس الاميون ريسبونس، احط ماده اخرى جنب الفاكسين او الماده الاساسيه حقتي عشان اثير استجابه اقوى للجهاز المناعي. ايش كمان ممكن اعمل؟
How to through the system. The system will be limited. We don't have the immune system. It's almost about 24 billion genes is there. So if we're going to weaken a part, we shouldn't listen always, to the research. Because research, we know it.
لا بس حتة اللي هو الادجفنت سيستمز هذه efficient وفعالة وعمل بيها في الريكامبينت هيربيز زوستر فاكسينز، ودتنا efficacy ريت مرة عالية. efficacy يعني efficient فاكسين كان، وللآن حاليا شغالين عليه. Did I get your questions? I didn't get your questions.
No, it's okay, but we don't have our own research, the Saudi. The one from here, so that we can from abroad we can get so many things.
طب من هذا المكان ممكن ننطلق احنا نزود عدد الريسيرش. We need really a local research. We need it. نحتاج احنا اكيد نزود عدد الريسيرش، بس عشان هم اوريدي بادئينه قبلنا في الدول الخارجيه فاحنا بنعتمد عليهم مبدئيا، وهذا ما يمنع انه احنا بالعكس عندنا فرصه جيده ان احنا نزود عدد الريسيرش. The last thing البوستر فاكسينز اللي هو احنا بنعمله في الاطفال الان. لاحظوا الاطفال في جداولهم احنا بنقول يطعم على 2 شهر، بعدين على 4، على 6. ايش الفكره من هذه الفترات؟ انه انا كل مره اعمل زي الريكول للاميون سيستمز، انه بليز جيت اويك، يعني خليك يقظ، لا تنسى هذا الفريم او الشفره هذه. نفس الشيء في الاطفال لو لاحظتوا في الكبار اقصد، في تطعيمات كل 10 سنين، في تطعيمات كل 5 سنين كمان مرة ثانية عشان أرجع أيقظ الجهاز المناعي وما يعني يفضل متذكر الشفرة هذه نفسها. هذه صورة طبعا لجدول التطعيمات حقت الكبار. if I'm not wrong I think this is it للكبار. مجدول فيها التطعيمات اللي الآن احنا حابين نبدأها اللي هو للأدلت ايج، وأكيد حقت الأطفال الكل الآن by now they knows اللي هو جدول تطعيمات الأطفال.
Thank you, Dr. Asana. Dr. Muhammad, how do you look into those people or those patients with comorbidities? Are they at risk, and what are their current status of immunization in our society?
Okay. Can you get the phone? Pointer, please. Assalamu alaikum wa rahmatullahi wa barakatuh. In the beginning, I would like to thank the organizing committee, the GSK, the FIX, the Saudi Society of Family Medicine, and Dr. Ashraf for the kind invitation. And I hope to have like a very nice lecture with us today. In the beginning, I would like to also to comment on the doctor questions. Yes, I think you are right. We are different in our culture and in our organisms. I would just like want to give you an example. For Clostridium difficile pseudomembranous colitis, the drug of choice was changed over the 3 years. So we started with flagyl like metronidazole. Then the Clostridium difficile became more resistant to metronidazole, so we changed it to vancomycin, oral vancomycin. Then after 1 year, we changed it to oral fidaxomicin, which is a macrolide. Why? Because it decreased the recurrence and it less resistant, okay? But we didn't look to our Clostridium difficile here in Saudi. Our Clostridium difficile in Saudi is benign, is not resistant yet. So we are, if we want to follow the standard, the international standard of care, we can use fidaxomicin and vancomycin. But most of the time, if we didn't find it, oral metronidazole is okay, because our Clostridium difficile, we already know, is not as resistant as the one in North America. So yeah, we have to put this and to consider this in our mind when we deal with infectious diseases here in Saudi. So for the comorbidities, I think we have like a combined relationship between the comorbidities and the infectious disease. So if we want just like to focus, let's say, on the cardiovascular diseases such as ischemic heart disease, heart failure, and diabetes, pulmonary diseases like COPD, chronic obstructive pulmonary disease, interstitial lung disease, with the common infection. Let's say the most common infection nowadays, COVID, influenza, let's say other respiratory viruses, and let's say also herpes zoster. So let's put them like in a scale and see how they affect each other. So the infection itself, it can make the comorbids worse, and the comorbids, it can make the infection also become worse. Let me give you an example. Let's say patient has diabetes, maybe borderline uncontrolled or uncontrolled. If this patient got like, for example, a community-acquired pneumonia due to viral infection, what these people, how can they present? Some people, they present as a diabetic ketoacidosis because the insulin requirements is increased with infection due to the stress in the body, and the normal response is going to be hyperglycemia, and if hyperglycemia is not controlled, the patient will be in the ICU for diabetic ketoacidosis or hyperosmolar coma. So we'll see that the comorbids, it got worse now. And how about the infection? So the infection also, those people will consider it as relatively immunocompromised, so the infection is going to be worse than any other bodies. Another example for COPD, chronic obstructive pulmonary disease or interstitial lung disease. If we look at those kind of disease usually happens over years. COPD, what is the most common cause of COPD? Smoking, right? But what is the smoking is gonna change the respiratory system. If you remember from the old days, the smoking will change the epithelium of the respiratory system from columnar epithelium to have a squamous metaplasia, right? So they will lose the cilia of the respiratory system that help us to clean the infection outside of our bodies. But with the smoking, this is not gonna happen. So again, that COPD is gonna be worse. So majority of people, they will be admitted to the hospital and maybe admitted to the ICU. And the infection itself, there is no any defense mechanism in the respiratory system. So the infection is gonna be very bad, and majority of them, they will be like ICU, such as acute respiratory distress syndrome, ARDS, which is one of the worst complications of respiratory viruses, and maybe like aggressive viral pneumonia, so they will stay in the hospital for a long time, and they will be exposed to the sequel of hospitalization. So hospital is not like a safe place for us or for the patient. To me, I always tell my patient, it's the worst place to stay at. Like I don't wanna go home now. No, if you are even like 50%, you can go home. Go home. Don't stay in the hospital. So that's what we are trying to prevent hospital-acquired infections. And if you listen to me, so the sequel is very long. I can like talk in a such topic for a long time. The series is very long and it's very bad on our patients. So both of them, they can affect each other very bad. Infectious disease and comorbids. If we move to the other part, which is the very bad part, the immunocompromised. If we can say the chronic, the comorbids, I like usually to categorize the chronic comorbids in the two parts, chronic illnesses and immunocompromised. And immunocompromised, those people, they are like suffering a lot when they got infection. Because of many things. Number one, they don't have immune system work appropriately. Number two, the presentation is very bad. The presentation, if you are not expert, you don't know what's going on. Patient, they just come with hepatitis. What's going on? And at the end, you will end by that the hepatitis due to varicella zoster. Like, what? Without rash? Yes, without rash. Without any kind of like pain? No, without any kind of pain. So the atypical presentation in such patients is also usually missed by us, and at the end it will increase the morbidity and the mortality for those patients. So this is the same thing. We said worsening of the chronic condition, the infectious disease itself. When the patient exposed to the infection, we are gonna get like the comorbids get worse. Like for example, as I told you, COPD with influenza, and also increase the risk of complication, as we just mentioned. Patients with, for example, having let's say viral influenza, they will like get complicated with ARDS, right? So if we are preventing those kind of comorbidities, I hope so. And if we cannot, so let's work on the preventable part, which is the infectious disease. And as we mentioned, increase the acute exacerbation, and usually that will lead to hospitalization majority of the time. And on the other hand, it will cause more complication to such patients with COPD. As our colleagues talked about the herd immunity, let me give you just an example. We always like the vaccination rate to hit the 75% to say this is herd immunity is already here. So the number of infection due to influenza, it will go down. But here, this is just an example throughout from 2015 to 2017 in European countries. Like none of them, they hit the herd immunity. This is our rule. Our rule here, and why we are doing all of these workshops, and why we are trying to educate the healthcare providers and to educate the population to try to hit this herd immunity line, and at the end, it will help all of us to decrease the risk of infection. And this is what happened during the COVID era. We were working hard to try to hit this line, and at the end, alhamdulillah, we were able to hit it, and now we are free of the precautions. Number of COVID infections decreased dramatically, and we would like to do like this kind of process with all infectious diseases. What are the reasons of people for under vaccination? So I can, this is, if you're dealing with patients, you will notice that. You will see like patients, they're not aware about the vaccination. A lot of people, they like, what is zoster vaccine? I don't know that we have a zoster vaccine. Like about influenza, they don't know that influenza is taken annually. They say like, I don't need to take the influenza vaccine, I took it last year. What else? Like for example, the Tdap. I faced many people. They got like injured due to like due to objects that they put them at risk for example, tetanus, and they never been getting the boosters. They don't know even if there is a booster or not. So lack of awareness is I think this is the main responsibilities on the healthcare providers. We have to educate them. We have to mention all the benefits of the vaccines to them, not only focus on one infectious disease. We have to have like many sessions of educating people. For me, I started that process like in my clinic. I was talking to one of our rheumatologists. I'm like, I need to see all of your patients. Is that possible? And he was like, why? I'm like, I want to talk to them about all preventable infectious diseases, because those are the people that they have the lowest immune system in our clinic. So let's try to vaccinate all of them. Let's try, leave that part to me. I will talk to them about all the vaccines. I will be responsible about bringing the vaccines to the clinic by requesting it, because many vaccines not in the clinic, not available in the clinic for the elderly people. They are like selective. Some of the clinics, they are just selective, putting influenza vaccine and Shingrix, and that's it. So we started, I would like everyone here to start this process. If you have any difficulties, I'm more than happy to help, and I know like many colleagues around us, they can help, but we need to work together to try to achieve this point. And certain vaccine safety. A lot of people, they said, if I get the influenza vaccine, I will get influenza. This is always happen. Once I get the influenza shot, 2 days, 3 days, I get the influenza. So that's mean influenza vaccine is causing the influenza. No. That's an incorrect concept. So we should correct that to them. Cost and reimbursement, I think this is, يعني alhamdulillah, حكومتنا وبلدنا alhamdulillah, يعني we don't suffer from that. All the vaccines that are available in the primary care centers for free. I think this part is not applicable here. Access. A lot of people, they say, they come in private clinics, they say insurance will not cover Shingrix, for example. So, that's it. I didn't take it. I'm like, you don't know that it is available in the primary care center, the government? He said, no. I'm like, no, this is where do you live? I live like in this district. Okay, in this district, the primary care center belong your building is giving the Shingrix vaccine. So just they need very minimal direction. Okay?
Yeah. Thank you so much, Dr. Muhammad. And if you agree with me regarding the underutilization or under-vaccinations in our society, it goes towards patients because they have vaccine hesitancy. So this kind of perception towards vaccine and the side effect, which is a real concern for them, and the vaccine fatigue that they have been passing through many items of different vaccinations, especially during the COVID. This is one item. The other item is related to us as a physicians for the vaccine recommendations. We have to be very much convinced that vaccine is the ultimate choice for all our patients, especially patients at risk, to prevent the vaccine-preventable diseases. And that's why we have to exert certain more effort to convince the patient and to learn how to have that unique consultations to convert the patient from the pre-contemplation to contemplation state and then move all the way. And then the third level comes to the healthcare system. You mentioned, alhamdulillah, in our country, everything is covered by the Ministry of Health, but there is another sector, which is a private sector, which is not covered by the insurance. So that's why another way to go ahead to the decision makers, especially Majlis al-Daman al-Sahi, to convince them that all the other vaccinations should be equally covered and reimbursed throughout the population sectors, regardless they are belong to the government sector or even the non-government sector. So this kind of move and community moves from different perspectives, I think we could tackle these problems to some extent. And now we would like to hear from you, Dr. Majid. You know that the IDF has been identified the Kingdom of Saudi Arabia in 2017, 15 and 17 to be one of the top countries in the high prevalence of diabetes. And we know diabetes is 25% of our population, so every fourth person in our community is a patient with diabetes. But this is the tip of the iceberg. Still, we have a lot of people in the pre-diabetic state, which has been estimated to be 35%. So 35% plus 25%, more than 55% of our populations in the dysglycemic state. So it means that our population at risk of having the consequences of having diabetes. So how you can shed a light on this kind of perspective in terms of the immunity of those populations, the risk of those populations, and the mortality which they are exposed by having certain disease?
Dr. Ashraf, for this questions, it's very important to address it, as provide us these data which explain we are in, I would say, endemic for diabetes, and we have to consider it as one of the planning in our management for any healthcare problems, in consideration the vaccine preventable disease. But let's think how this would be affected to the immunity, as explained my colleagues, regarding the immunosenescence, regarding the effect of the chronic disease, the immunocompromised. With diabetes, that definitely would make things worse. So the body would be what? Would be expected to be risked. If they have the risk, that would be more risky to have high mortality and morbidity. So simply, anyone have a diabetes, you could have, a neuropathy. So that will be ended by ulcers. So they will have an ulcer easy for any organism to be into the body, number one. Number two, we think also about for the diabetes, diabetes mellitus number one, which is usually autoimmune disease. So that's in a direct way will affect also the autoimmune system and affect the immune system of the body. And if we think about the hyperglycemia at the beginning, that definitely will affect the cellular immunity, and with the chronicity will affect the phagocytic function of the macrophage, and also will affect the complement and inhibit the complement system. So all these make us, those patients, diabetic, risky for any communicable disease. Especially for those which can be prevented, okay? I would say flu, pneumococcal disease, herpes zoster, hepatitis, tetanus, diphtheria, pertussis, all these, people, this kind of group of patients, diabetic would be risky. So we have to sit with those patients, we consult them through our clinic, and during counseling them, we have to explain for them why they are at risk for the disease and why this could be happen, so they're providing the appropriate vaccines. So, as we mentioned, this is an example of the vaccine available in our hand to help those patients, for example, flu vaccine, Tdap, hepatitis B vaccine, the pneumococcal vaccines, the conjugated one and polysaccharide one. Okay, and the COVID-19, definitely we have some of data now, we will show it, how can this help, and that explain those people have a risk of diabetes, they have high morbidity and mortality, and definitely those vaccine, it's targeted for those even less than 50, if they are 80 and above, and have a diabetes, so we are focusing to those group of people to be vaccinated. As we mentioned and explained, the risk how can be developed. However, these some of the studies here just explain how the risk would be increased. For example, be double among those between 23 to 60 to have hepatitis B if they are diabetic. Imagine that the person would be having hepatitis B, and that will be exposed to the cirrhosis, hepatocellular carcinoma. With this, availability of the vaccines targeting such disease, that would decrease the risk of people that could develop such disease. Again, during the COVID era, lots of study has been, reporting regarding those having diabetes, and they reach to 80% of those uncontrolled diabetes, they have a high morbidity and mortality. So simply diabetes, and as we know, this is one of the challenges here in our health system. For I think it needs to be addressed by the different health sectors, government and private, and also others governmental sectors, to reduce the risk of diabetes. But with this, definitely will be increase the risk to expose for any infection disease.
Okay, thank you so much for this elegant answer, Dr. Majid. And now we'll move to Dr. Asana. How about those people with the respiratory conditions? What are the risks and what are the recommended vaccinations that you would like to recommend, Dr. Asana?
Okay, thank you, Dr. Ashraf. I wanted to أنا أبغى كل واحد منكم يتخيل معايا لو عنده عمارة والأساس تبعها ضعيف، يقدر يبني؟ كم دور يقدر يبني على أساس ضعيف؟ يا دوبك على قد الأساس الضعيف، بس لو الفاونديشن تبع العمارة ممتاز، إيش حيحصل؟ أنا أقدر أضيف أدوار زيادة. إحنا ليش بنتكلم عن respiratory disease specifically؟ لأنه تمثل 60 ل 70% من الحالات اللي بنشوفها في البرايمري هيلث كير. I don't know about the hospitals، أكيد هم بيشوفوا شغلات أخرى، لأنه في النهاية إحنا برضو بنكمل لبعض. We are concerned about respiratory disease because it's the commonest، هي الأكثر وجودا يعني، وبنشوفها تقريبا معظمنا as health care providers. So patient with respiratory conditions زي الأزمة، COPD، cystic fibrosis، هل فعلا يحتاجوا أنا أطعم هذه المجموعة ولا ما يحتاج؟ Why we need to vaccinate those people? Do we need؟ هل نحتاج نطعمهم؟ ليش أنا ربطت فكرة الفاونديشن؟ لأنه هم أساساً الجهاز التنفسي عندهم ما هو جيد زي الناس العاديين، بالتالي هم الفئة المستهدفة اللي لازم أطعمها. طب what kind of vaccination we need to vaccinate those people؟ الأزمة مثلاً، إيش يحتاج مريض الأزمة؟ What did you think؟ مريض أزماتيك بيجيك على طول في العيادة، حتنصحه بإيش؟ أزماتيك، أزمة patients. What kind of vaccines؟ ما أسمع. اللي هي النيموكوكال. طيب أول واحدة كلنا الآن حاليا بناخدها إنفلونزا، فلو شوت. طيب نيموكوكال، what else؟ طبعا لما حنتكلم عن الأزمة حنشمل معاهم COPD والcystic fibrosis which is rare disease، بس موجودين برضو interstitial lung disease، هذول كلهم يعتبروا patient with chronic respiratory illnesses. Flu shots, pneumococcal vaccines. I heard some things. Haemophilus influenza. Why they need Haemophilus influenza, those people? I cannot hear you. أنا I agree with you، هي واحدة من التطعيمات اللي مهمة، بس في هذا في الادلتهود لا ما بنطعمهم، بالذات الناس اللي عندها respiratory disease. ال most important things الانفلونزا vaccines، النيموكوكال vaccines، التيداب، تيتانوس، ديفتيريا والأيسيلولار بيرتاسيس vaccine، الزوستر vaccines والكوفيد. طيب regarding the chronic respiratory illnesses زي COPD، الأزمة، cystic fibrosis، and other chronic lung disease such as chronic emphysema or bronchitis. Patients with chronic respiratory condition are at increased risk of influenza-related complications. We all agree، لأن الفاونديشن تبعهم أساساً ما هو جيد، فبالتالي it's expected إنه lower respiratory tract infection will be more, hospitalization and death, and اللي هو increase the hospital admission and hospitalization for asthma specifically يعني. The benefit of influenza vaccines. هل influenza shots beneficial for those people؟ مفيدة؟ إيش فائدة إن أنا أطعمهم؟ في comments it's always coming to me my clinic. دائما يجي المريض يقول لي والله يا دكتورة بعد التطعيم حق الانفلونزا أسوأ انفلونزا جاتني. which is بتحصل معانا كلنا. أنا أسوأ انفلونزا أخذتها بعد تطعيم الانفلونزا. ليش؟ لأنه we did not say to you that influenza give you 100% protection. هل إحنا بنقول إنه it protect you 100%؟ there is a percentage. معناته definitely some of those people they will get an influenza. بس الهدف من التطعيم decreasing اللي هو morbidity time إنه ما يمرض فترة أطول، إنه ما تجي الأتاك على فترات متكررة. طيب. Influenza vaccine reduce respiratory illnesses, asthma exacerbation, as well as COPD, hospitalizations, as we mentioned before. And definitely طبعا في النهاية it will decrease mortality. I love graphs. It gives us صراحة to the point. Here a nice graph showing the proportion of people vaccinated and the age category of people testing positive for influenza. We have two colors, that orange and pink colors. Those people get, both of them they get vaccinated. بس شوف الناس اللي أخذوا here after they get the vaccine هنا في اللي هو في overall 59% of those people get the flu shot ولا هو الفاكسينز. البروتكشن ريت قديش عالية بعد الفاكسينز. وآخر حاجة في الناس اللي more than 50 الأورنج الأورنج those flu positive والبينك flu negative قديش البروتكشن ريت 73%. طيب الانسيدنت في pneumococcal pneumonia in adult with underlying condition in USA from 207 ل 27 ل 2010. This is a retrospective analysis medical claim data from USA found that there was a 7-fold higher incidence of pneumococcal pneumonia in adult more than 65. Definitely طبعا community acquired pneumonia. Here, impact of pertussis in patients with chronic respiratory illnesses. What did you think in a patient coughing most of the time? أكيد مع الكرونيك cough حيصل له respiratory failures, incontinence, lack of sleep, a lot of things just with chronic cough. Insomnia, apnea, weight loss, urinary incontinence, syncope, rib fractures, least commonly pneumonia and otitis media, and finally death. Patient can experience negative consequences from pertussis for more than 6 months. There is increased risk of pertussis in patients with asthma or COPD associated with chronic economic burdens, which is expected. Chronic respiratory disease and Tdap, CDC recommendations. 1 dose for people with chronic respiratory conditions, option for decennial booster dose, wound management and catch-up immunizations. بالنسبة للناس اللي تنجرح، احنا دائما لما يجونا في الرعاية الأولية بنقول له طالما هو عنده جرح طبعا جايين من برا ومجروح لازم ياخذ اللي هو التيتانوس. وهذه طبعا أكيد بتأكدها المعلومة هذه السلايد. الامباكت اوف COVID-19 in patient with chronic respiratory disease. اتوقع في فترة الكوفيد كلنا عانينا بالذات لأنه هو it is a respiratory illnesses وشفنا تأثيره على الناس وعلى الهير كير providers. Here the outcome of patient hospitalized for COVID-19. يمكن أنا ما عندي خبرة جيدة في الناس الهوسبيتالايز زي الفيزيشن زي الدكاترة في المستشفى. أنا حقيقي كنت أتمنى الناس اللي في المستشفى يشرحوا هذه من منظورهم هم as a specialized. What did you think, doctors?
Yes, so if we talk about like COVID with the chronic comorbidities, that's very well known like in the studies and in the hospital. So if we looked about the patient with ischemic heart disease, the diabetic patients, patient with COPD, they usually has a higher rate of complications. So majority of them, they are like in the ICU if they are in the hospital and they are not vaccinated. And the mortality rate among those people higher than compared to other population. Okay. That's regarding just COPD. Influenza, the same thing. So in the American Heart Association, they made it clear like patient with the acute coronary syndrome, like before you discharge the patient, give him the influenza vaccine. Because influenza vaccine is associated with a higher rate of mortality in those kind of patients. And now, also in American Heart Association, they mentioned the point of stroke, that one of the things that can prevent stroke is the herpes zoster vaccine.
Yes.
Because the herpes zoster can cause cerebral angiitis, like kind of vasculitis, and it will increase the rate of ischemic stroke and hemorrhagic stroke. And with the vaccine, it decreases by 15% those kinds of like either ischemic or hemorrhagic. So just to answer the Dr. Sana questions, yes, those people, they have many complications, and yes, those people, they have a great protection from the vaccine. And just I want to comment on your point, like when you said the patient told you like I got the worst influenza. So usually they are right. The protection percentage, if we talked about the influenza, is like about 60 to 70% from getting. So they were told like, why you want me to get the influenza vaccine if the protection is 60%? But you didn't let me to finish my talk. 90% it prevent hospitalization. 95 to 99% decrease the risk of ICU admission. So I just like asked them right away when he told me this common sentence, like, when you got the influenza, where you have been during the influenza time?
Which is significant.
I'm at home.
Which is significant.
See, 90% you are not in the hospital, 95% you are not in ICU. So alhamdulillah.
Yes. Yes.
Yep.
Be risky for other strain. So once you're infected, you'll be affected or infected because of one strain. However, the quadrivalent vaccine that we have, the tetra vaccine that we have for flu, with covering H1N1, H3N2, the strain B, the 2Bs, okay? So in Mecca, for example, the risk would be high, and that's, so even if they're infected, they could infect it also after 2 weeks from the first infections. So it's totally, we have to be support and encourage people to be vaccinated, specifically those high-risk groups and those also healthcare workers. They to protect themselves, to protect their families, and also protect the patients, as they could easily transmit the infection to others.
Yes, thank you. And the virulence of the organism itself, the influenza virus, very clever virus actually, getting mutating most of the time. That's why we need to add more and more strain in the vaccines.
Okay. Yes. Can we have the mic, please, here? Rahman.
Thank you very much for this very enriching presentation, for the vaccines and the benefits of the vaccines. And as a physician for a long time, I have been faced with people whom they are totally against the vaccine. I can just give an example for the COVID. I have people whom they refuse to get the vaccine, they refuse to give their children the vaccine. And now, after the things has gone somehow, they say, you see, we told you we don't need the vaccines now. All the talks about the vaccine now, it's coming up. And people are saying, people developing Alzheimer's, people developing some kind of problems, after the vaccines. So convictions now, it has become a little bit difficult, especially after the COVID-19 vaccination era. Also some people, from the old generations, they say that vaccinating the children might cause autism. And these kind of things, it's really giving us hard time, to convince those people, to be vaccinated. So I just want you to see if you have any comment on that. Yeah. Thank you.
Expect to see in our common practice. We have to stay with people and to address some of the side effects or possible adverse events of vaccines. Still, this is the chemical substance we inject the body. However, we have to also explain for them, and we give it time. When we consult for the vaccine, it shouldn't be in a minute, I would say. This is where we have, we'll have, I would say, we'll take a part of your clinic and part of your counseling with the patient. simply by explaining what is the risk could be happens if they're not having the vaccines. As we explained now, some numbers and shared by my colleagues about if someone not vaccinated, they could develop, the risk of COPD, diabetes, would be increased the risk for the vaccine-preventable disease. This is very hard to be explained, I would say, in a way that acceptable, I would say in a language that can be understandable by the patient even, okay? And we have to be patient with the patient for their questions. We expect that could have, some of concerns. However, as a rule, we shouldn't lose any opportunity of vaccine. We have to vaccinate them at the same time. But if he has, or she has, they want to rethink again, we could get another appointment. So that would be easier to take their time to think. And we can document the system that the next time we expect them to take the vaccine. So we understand this happens everywhere. Unfortunately, the social media could have a role for the spreading of rumors, etc. But no doubt about the effect of the vaccines for along the history. The smallpox has been eradicated because of vaccinations. The COVID-19, although people could be infected, but decrease, dramatically the risk of the risk of the admission to the ICU mainly, and people died. So we increased the herd immunity. Still the infection there. Still there is a mutations. Still there is a new vaccines try to accommodate for the new epidemiological change of the strains of these, virus or bacteria, whatever the pathogens. So in general, we have to be proactive. We have to understand the concern for the patients. However, we have to be patient with them to explain the risk and the importance of the vaccine that be given to them.
Yes, I want to add one point. We need to be really calm, open, non-judgmental to explain the ambivalence, التناقضات. Because أنا دائما أقول لغة الأرقام لا تكذب. لما أنا أتكلم مع المريض حسب مستواه العلمي وحسب فهمه، أنا بشوف الصورة من برا كم عدد الناس اللي حصل لهم hospitalization، قديش واحد ما جاء الانفكشنز، هو بيقارن نفسه بنفسه. أنا ما جاني المرض، بس غيرك كثير جاهم وتعبوا، غيرك كثير عدوا. التطعيم منع أشياء مرة كثيرة هو مو شايفها. فهمت شو أقصد؟
Throughout the years, we have a compelling evidence that vaccines are very beneficial throughout the years. And it saved the life of humanity through vaccine-preventable diseases. And this is true that still we have certain side effects out of all the vaccines. But we have, at the end of the day, we have to weigh the risk and benefit. How many of our populations they have been subjected to this kind of risk? How many on the other extreme they have got the benefit of having the vaccine protecting them from devastating diseases? So it's a weighing risk and benefits, and this is exactly our role as a physicians to enhance the proper information to the patients and to disseminate it across the different channels of communications and to use the mass media and to intervene with those statements which is falsely changing the mindset of our community. So when we get to patients who are reluctant or even hesitant or even objecting to take the vaccines, we have to be very defensive and we have to do the thing right. I always remember my patients who are coming for me for the first time to be diagnosed, a patient with diabetes, and his hemoglobin A1C is 10 and 11, and it's extremely high. When I start asking him that I will give you a medication, he will say, no, doctor, I'm afraid of the side effect of the medication. I said, okay, think about the side effect of the disease. You are going to lose your eyes, you are going to have MI, you are going to get your limb amputated and your kidney transplant. So then and only then he will realize how to weigh properly the side effect and the benefits he's getting. So I think it's an art that we have to learn, counseling of this kind. It's a very unique counseling sessions that we have to learn how to do it in a very short period of time. And then we can use the other educators because we work in a multidisciplinary team approach. So our colleagues who can educate the patient in a proper setup to change their mindset towards the possibility. So Dr. Majid, now we would like you to shed the light on the Saudi National Immunization Program for adults. There's many components out of it, and I think we would like to have your insights.
Thank you, Dr. Ashraf, for this questions. As you know, the Saudi National Vaccination Program, which is known here as ABI, this is a medical or terminology used in public health regarding the immunization program in each country, which is each country they decide to say this is the best program that we can implement it for our population. So as we know that the one that we provided for the infant and children, we have something now, and I would say that introduced through the MOH, which is already I think available at the website of the MOH. Anyone can access to it. And also anyone, I think, could access to take their vaccine to the Sahati application, so can they find the nearest primary healthcare to take the vaccine. So simply, it's the adult one, which is, I would say, include elderly, adult, and elderly. It's related to the I would say, the risk of age. Okay, so they consider the age is the one that of those people they have to receive the vaccine. So they introduce since I would say 3 years the human papilloma virus vaccine, the HPV vaccine, and that there is a campaign that started in the school since 2 years and is targeting year 6 and year 7 and year 8. Since 2 years, and it's successfully now implemented at the school. In addition to that, they have also introduced the meningococcal vaccines, which is focusing the quadrivalent one, the ACW1351Y vaccine. And we also have for those above 50, the herpes zoster vaccine as a 2 doses, and those above 65 to have the conjugated and polysaccharide pneumococcal vaccines. So this is the vaccine that we have to be given. In addition to that, we give in every year for the flu vaccine and for those having a risk for the injury, for the Tdap, and for the pregnant to be given for the third trimester, the Tdap vaccine, then TD. For the normal people, if they receive the Tdap every 10 years, to receive the tetanus diphtheria vaccine. In addition to that, we have something that, according to the assessment for the, I would say, the serology. So, for example, for hepatitis B, for measles, mumps, rubella, and for varicella. So those have to be assessed and given a vaccine. And especially those high-risk group, I mean the healthcare workers and military. So this is based, I would say, the vaccine which for the adults is now available at the kingdom. This is, as I mentioned, it's available that everyone can access to the website of the MOH, and it's, as I explained it, so influenza given 1 dose annually. So that's vaccine given every October until the end of March at the season of the risk to get the infection. So we encourage everyone, especially those high risk, anyone above 6 months old, pregnant women, those having a high risk definitely will be considered to get the vaccine. Tdap or TD, as explained by colleagues, that had been given for the Tdap, then given a TD as a 10 years as a booster dose, and also for the pregnant to be given every, with every pregnancy, that's the third trimester to be given a dose. MMR and varicella hepatitis B based on the assessment of the serology, so those not immune, and there is no evidence of immune, they have to be vaccinated. We have 2 doses given for the measles, apart of 28 days, 4 weeks, and varicella for 2 months, 8 weeks, and for hepatitis B, the normal schedule given for the adult, 0, 1 or 2, and 6 months. And definitely we encourage to assess the hepatitis B surface antibody after 6 weeks from the last dose of hepatitis B given up to 6 months from the first dose. Then for the HPV, as this is the new vaccine has been introduced here for the female, and it's considered as 2 types of doses can be given. I would say the 14 age and less would be given 2 doses, 0, 6, or 0 a year, and above 14 years, which is 15 and above, until 24, they have to be given to the 3 doses, 0 to 6. Those above 24, 26 years, they have to can take the vaccine based on the risk and clinical risk assessment. The meningococcal vaccine, it's a vaccine that is well known. It's very important to minimize the risk for meningococcal disease, especially in crowded areas, especially on the risk of mass gatherings. So we recommend, and DMOH recommend, those not receiving the meningococcal vaccine to be vaccinated and to receive it every 5 years. So this is for the conjugated vaccine. This is the mainly again for the herpes zoster. We have to vaccinate those people for 50 years as a consider, even if they're healthy people, and definitely with those having the high risk group, they have to be assessed by a specialist, so can be given for the immunocompetent, immunocompromised, if they reach the 18 and above. So this is simply the program that's for the adults, including the adolescents and elderly here in the kingdom.
Well said, Dr. Majid. Now move towards discussing the vaccine with patient. But I would like just to highlight that if you have any questions, so just keep it at the end, we'll have questions. And I would like to invite our virtually attendees to put their questions in the Q&A box, so we'll be able to forward it to the speakers to answer it. So this is a question now, what is the role of the primary healthcare or the primary healthcare to discuss the vaccine with patients? So I think all of us will participate in this. So Dr. Sana.
طيب أنا صراحة أشكرها اللي سألت هذا السؤال لأنه مرة سؤال مهم وجيد. If we did not lead our patient, they will get led by others. لو إحنا ما قدنا المجتمع سيقادوا بالآخرين, الانفلونسرز, social makers. So we need to lead them. We have a big role really as a primary care physician. المريض أول محطة له للرعاية الصحية هو البرايمري هيلث كيرز. هو أول واحد يجيك أنت as a primary health care، وما بيروح المستشفى إلا بريفيرال from us. أكيد لهم respect other specialities، بس we are the gatekeepers. We can do a lot of change. إحنا بإيدنا يعني نعمل نقلة نوعية في طريقة تفكير المريض. You know how to counsel them regarding the importance of immunizations, the importance of taking your اللي هو الvaccination schedules. كثير من المرضى الآن يجي يقول يا دكتورة هل هو في تطعيمات للكبار؟ نقول لهم إيوه. الآن nowadays we are starting to implementing such a vaccines عشان لقينا الإفكت ومنفعة هذه التطعيمات. زمان من كم سنة راحوا كنا بنعاني في تطعيمات الأطفال. إلى 10 سنين سابقة جاتني مريضة في إيدها طفل عمره 3 سنين، يا دكتورة عمره ما أخذ ولا جرعة. تخيلين الآن الأم حريصة كل الحرص إن هي تطعم وتتابع تطعيمات الأطفال. ليش إحنا ما نزرع هذا الشيء حتى في الكبار؟ إن يكون الشخص الكبير as an adult هو مسؤول عن صحته، لأنه في الحقيقة صحتكم أو صحة الفرد هو مسؤوليته. إحنا كأطباء بنرشدهم. We are guiding them whether to go to the right or the left، ونقول لهم إيش الأنفع لصحتهم.
Thank you, Dr. Asana. I remember one of the studies which highlighted this issue and the role of the healthcare providers in convincing a patient to have the vaccine. And the study concluded that the number one most influential person to change the mindset of those people is the primary care physicians, yes, or the private physician or the family physician who is yes, building a long-term yes, relationship with the patient and his yes, family. And he's the advocate for the family and he's yes, the trustworthy person. Who comes next? Guess who? The most responsible member of the family who is more educated towards health. He will be the second person to be asked by the members of the family, and he has the influencing capacity to change the mindset of the whole family. So remember, private physicians or family physicians or primary care or any physicians who could build a good relationship with the patient and his family, and then we have to invest in the members of the family to allocate one member who has this kind of health knowledge to convince the other member of the family to have the vaccine. So Dr. Hassan, what is your...
Well, I mean, health literacy, it's important. So we need to study it first. I do it honestly with my patients to see the level of their awareness about their health, the knowledge, their knowledge about the chronic diseases, about their medications. So patients with low health literacy, evidence-based, they are more likely to be admitted to the hospital, more visiting to the ER, readmission rate is high because they don't have that much information about their health. So the recommendation out of this is that we need to first to find those patients with low health literacy. Then we need to educate them. Unfortunately, we don't have that privilege of time to sit with the patients, specifically when we are talking about in private sectors, you have only 15 minutes. So should I go through his medical issues or should I educate the patients? There's a different way to deal with that. We would slice the visits to different visits, or we would direct the patient to a medical educator. And we can see that with the diabetes program in some hospitals. They have a special person as a health educator to give the patient more information about the chronic disease, about the benefits of medication compliance. So while we are talking about health literacy, that would guide you from where you will start the discussion with the vaccines. So do you think that starting a discussion with a person with high level of health literacy, it might be much easier to discuss and to open the discussion of vaccine? With those patients and specifically older adults, unfortunately, we have most, I wouldn't say most, but a lot of them, they are not educated, even they don't know how to read or write. So at that level, I think from my experience, building a trust is the first thing that you do. I don't advise to start talking about vaccines with the first visits. You need to first have their trust. They need to see something that you provide to them on their health, working on their medications, having this feeling of friendly feeling about taking care of him. It's not about taking care of only the medications and the numbers. We are seeing the patient, listening to them. I think opening up the discussion with the vaccine, after the first or the third visits, it will be a very wise move with each physician.
Thank you, Dr. Asim. I think to have a very strong recommendation for vaccination, definitely, as it was stated elegantly by Dr. Asim, you have to build a good relationship with the patient to have to attain and to gain the confidence. And then you have to share the reason why the vaccine is right for the patient. And now we are living in the era of customization based on the patient profile. So profiling the patient, you tell him you're an elderly patient and you have this kind of comorbidities and these are the risks. And then that's why I would recommend to have this kind of vaccination, which is fixed for those people who are having the same profile of you. So this is the sharing the reason. And then you go for highlighting the positive experience of the other patients who have been protected very well by the disease after taking the vaccination. And then you have to address the patient questions. We are talking about the idea, concern, and expectation. Patients are coming with certain idea and certain concern about the side effect, and then you have to clear it up in that particular setup and encounter, and remind the patient with the vaccine, protecting their loved people, the elderly patients in your home. They will be protected if you give them the vaccine and you take the vaccine, and your kids as well will be protected if you take the vaccine, and so forth. And then explain the potential cost of getting influenza. If I get diseased, I'll be not able to go to my office, I'll be losing productive days, and so forth. So these are the 4 components where you can highlight the positive way of recommendation of vaccination. Dr. Mohammed, what is your thoughts on this?
I think I'm going to talk about a little bit away from the primary care. So let's talk in the hospital.
Yes.
When in the place that I was trained on, they were initiating the discussion with all inpatients, patients about the vaccination. So the main target is to give all the hospitalized patients influenza vaccine and to know who is at risk to get the pneumococcal vaccine and to see who can get the Shingrix vaccine or the recombinant zoster. So and then we were working inside the hospital, try to classify our patients and try, like for example, all the transplanted patients, they receive the Shingrix vaccine. We have to make sure if they are in the hospital or in the clinic, we need like to give the Shingrix vaccine as much as we can. Influenza vaccine, all the hospitalized patients should get the influenza vaccine unless the patient like refused completely. All the hospitalized patients should get the pneumococcal vaccine that the patient that they are at risk or they meet the requirements for pneumococcal vaccine. And this is, I know this is, it will impact our like, it will like have more burden. Like, you know, we are treating acute illness and at the same time we are doing like some sessions of education. But I know this effort, we're gonna like gain the benefits of that like at the end, inshallah. But I think this is a responsibility for all healthcare providers, like in the outpatient setting and the inpatient setting. And we mentioned that the reason of underestimating the vaccination, we have to go through them and try to correct all the misconceptions and try to do more awareness. And at the same time, in the hospital, the access is very easy. You know, if you just agree, I will give it to you now. But in the outside, we have, if I don't have the vaccine, I have also to direct them from where to get the vaccine. Because like, I think they will lose the trust if you tell them, okay, talking about vaccines and you spend like 5 to 10 minutes, then you don't have the vaccine. I think doesn't make sense, you know? Yes.
Dr. Majid, what's your thought regarding the role of primary care physicians or
Yeah, that's very important. I think that we have, first of all, in addition to the healthcare workers there, they have to be educated about the importance of the vaccine. We have to provide, according to the studies have been discussed, the vaccine hesitancy and why people they don't like to be vaccinated, to have, first of all, the accessibility of the service. We have to make it easy for people to book and come to the clinic to be vaccinated. This is very important. Otherwise, the people, they will, you know, they will have difficulty to come to the clinic and to find an appointment to be given the vaccine, number one. Number two, we have to help even the nurses to give him the standard order, what called standard order. So they are able to assess the patient, those without the risk, so she can have the right to provide the vaccine. So this is very important. We increase with respect, of course, the medical legality, and when we educate the nurses about when she or he could refer the cases to the physician. And definitely, I think you mentioned that in your points, the role model, even for the centers, it's very important to be, you know, encourage their staff to be vaccinated. For example, we started usually in our hospital, our chairman, they started to be vaccinated. We go into the higher rank in our organizations and we take a photo. That will be will be like, I would say, you know, it's spread for everyone that they're confident this vaccine is effective and can be, you know, taken. So I think even the administration of the primary health care, they have to be, you know, the director there, they have to be convinced their colleagues, physicians, healthcare workers, nurses, about the importance of the vaccine. Definitely, if there is a vaccine clinic, that would be better. I know that there is difficulties, but if there is a vaccine clinic, that will be easier to have a logistic supply for all available vaccines and for someone dedicated for the vaccines who are able to be meet the patients and the people, to convince them and to you know, to make easy the vaccination process to be, and the vaccine campaign to be successful easily.
Thank you, Dr. Majid.
And I received a text message from MOH. I think most of us received it, and this is the point of the accessibility of the vaccine. أقرب وأسهل، اطلب لقاح الإنفلونزا الموسمية لتأخذه أنت في مكانك عبر تطبيق كريم. This is very nice. This is how the MOH trying to reach people, very accessible. For 8 years, United States, we don't have that much, I mean, part of facilitating thing for the community to have this vaccine. So the extreme thing that happened, if you remember, you would find the flu vaccine in the pharmacy, but no one would bring it to you, and as simple as doing Uber. It's like Uber for vaccination. This is very nice move. That's toward having this kind of, immunity, increase the immunity of the system. MOH realize that by having the vaccination, that would decrease the number of ER visits. That would decrease how much does it cost to have Uber to visit the patient at his home, at his convenient place, and to have the vaccine there. And if you compare it with the expenses of having the patient visiting the ER with the admission, and this is a lot of things. So this is what Dr. Majid mentioned about the easy accessibility to have those kind of preventive measures.
Yeah, actually, this is exactly what happens during the COVID-19 pandemic. In the private sector, we thought out of the box how to reach for our patients, especially in Ministry of Health during the COVID-19, when there was a dramatic drop in the vaccination coverage for adult and pediatrics. So we mobilized our home healthcare team to vaccinate all the adults and even pediatrics at home, free of charge, so there was no extra cost. And then we requested them to come in their own car without getting into the hospital because of the fear of the infection. So we vaccinate the adult and even the pediatric in their own car in the street. So this was one of the ways, to be more accessible, to be more attentive and more available to patients. And again, I think it's by understanding the behavior and the perceptions and the culture of our community, we understand exactly how they behave, and we can do some kind of unique strategies to tackle the hesitancy. I'll give you an example. In my clinic, after many years, I realized that I have to develop my strategy. So for example, a patient who is patient with diabetes, and I'm treating him, and I find that he did not receive the pneumococcal or the shingles. So at the end of the consultation, I'll say, Mr. Muhammad, you did very well today, and I'm going to change this kind of medication to optimize your blood sugar better, and I'm going to add this medication for you, and I will request for additional consultation for other specialties, and I'll give you today the vaccine, and I would like to come after 2 months to have the other dose of the vaccine, and please come after 3 months to receive the follow-up for your diabetes. So I insert this kind of solid, assertive statement of having the vaccine within the management plan. So he'll have no choice but to accept it fully without fragmenting it to one piece that he will be rejecting. So it went very well, in fact, and I feel if you just try it in your own practice, you will get the benefits of having this kind of modality and strategy to overcome the hesitancy. Okay.
And by the way, I had the privilege to work with Dr. Ashraf at his clinic. He is treating his patients like a VIP, all of their patients. He stepped out of the clinic with his patient carrying all the paperwork and to the nurses station, pointing out all the nurses, and he is very busy and he's doing that. This is a good thing, and I think that the trust that the patient looking for.
Well, this is how we
are. I will do it. Well, if you say that to me, I will do it definitely with this kind of treatment.
Thank you so much. We are all privileged to deal with the most precious thing in the whole world, which is human being. And the precious thing is human being is his health and wellness. So we are privileged as a physicians. Okay, so if you just go into 5 steps recommendation for vaccinations, the first step I think we have to look into, assume person will have immunization. So this will take it for granted. This time, this patient will take his vaccines during this consultation. And then we move to the second step where we give the strong recommendations, the strategy that I told you. And then the third step will explore the reasons for hesitancy. Just flip the patients and look into why he is resistant. What is his concern? It could be something very small, very unique, very trivial, something you can encounter or something you can look into. And then the fourth step, ask the permission to address the concern. And this is, you have to be holistic and you have to be realistic, and you have to understand the patient from his own perspective. And finally, ask again if you can immunize, and definitely, inshallah, the patient will be agreed on this. So then we will come to the vaccine administrations. Of course, there is 7 rights for the vaccine administration. the right patient. So you have to identify who is that particular patient at risk that is fit for that particular vaccine, and the right vaccine. Out of all the vaccine, you have to have your own vaccine which is fitting for that particular patient, the right time, the right dosing, and the right route, and then the right site, and then the right documentations. If you don't document it, it will be lost, and then that's why. So this is the 5 rights of the vaccine administration. Dr. Majid, please.
Those responsible about the vaccine campaigns and vaccine programs to train the staff who operated such clinics. They need updated training. I would say every time we have a new vaccine, different roads, different storage even. If you remember, COVID-19, we have a different, I would say, types of COVID vaccines, which is some of them need to store at -80, some of -20, etc. So all these, have to be people to be explained to them very well. As explained by Dr. Ashraf, so this vaccine is a chemical substance that we have to consider the cold chain when we move the vaccine from the main storage to the clinic. How can we, receive such a vaccine, and how can we store it exactly in the biological fridge, connecting to the emergency electric generator in case of the losing of the electric, so we not lose this amount of vaccine that because of the simple fault of electricity. And people when take it, and even the distribution of these vaccine, we have to be careful in which part of the fridge can be safe, out of the light exposure when they receive the vaccine, how many vial can be taken. Some of the vials will be given for 6 patients, 5 patients, etc. So these variables have to be trained for the nurses who work with such vaccine. Similar for the order that we given for the nurse have to be clear. The injections as IM, sub-Q, intradermal, the amount of dose. Sometimes we need to double the dose. So we have to be explained very well for the nurses. And documentation, I think that now we have a good, I would say, a system that's introduced by the MOH, which is called NVR as abbreviation of the system, the National Vaccination Registration System. This is very well. I think we have to be proud about these vaccines that expected all vaccines that would be received since this year, and they give the accessibility to document the previous vaccine, so you will be able to know which vaccine you received in Sihhati application. So whatever the vaccines, I expect those receiving flu vaccine this year, they could, print certificates regarding that the vaccine has been received. So this is very nice for documentation. So you need this either for your, whatever that the need, when you need the vaccine for traveling, or whatever that you need the vaccine, and even for you, when you receive this vaccine, which batch even, as to monitoring the quality of the vaccine has been given, and also for when I have to receive the second dose. So this is, the whole thing is very important to having a successful vaccination campaign.
Thank you, Dr. Majid. I think it's those who have HIS system, we can enhance our health system to be able to identify and pick those people at risk who are coming to our healthcare facilities, and to pinpoint them and to give them the vaccination, not to have a missed opportunity of having those people leaving the organization without having the vaccine. I know some of the organization, they have adapted the 6 vital signs is a question about vaccinations. For example, the patient, when he goes to the nursing triage, the nurse will take all the vital signs, and the 6th vital sign will be asking the patient, did you take your vaccinations for pneumococcal, for herpes, for whatever? So if he said no, she will direct him to the vaccination clinic. So this is it's a checkpoint. It's like a police stations where we can check everything and make the clearance for those people at risk to leave or to stay. And if we just look here into the steps of the vaccination administrations, of course, there is a pre-immunization counseling. And I think the first dose will be given by the physicians because we are more trustworthy. And then we have to delegate, the authority for our colleagues in the educations and educators to take part of the more details about the counseling and the social workers as well. And then we go to the vaccine preparations by the nurses, injections of the vaccinations, and lastly, it will be monitoring after the immunization. But I truly believe that there is another missing fifth and sixth step. The fifth step is to connect the patient before he leaves to the second dose or to the other vaccination that he needed in the future. So it's a kind of engagement and connections. Not only this, but also I like one of the initiatives which has been done by one of the healthcare organization. Once the patient took the vaccines, there will be a question for the patient. Do you have any risk population, any members of your family at risk? How many elderly patients you have at home? How many pregnant ladies at home at this point of time? How many kids they did not receive the vaccination? He will mention, and then those people will be picked up by the nurse, and she will request them to be brought to the healthcare facility. So this is kind of getting out of the box and trying to engage ourselves with the community rather than getting ourselves limited to the boundaries of our clinics or even the compound of our hospitals. So this is how we can serve our population better. Anyone would like to talk about the pre-immunization counseling? How do you counsel your patients? Any thoughts?
Let me just one point came to my brain when you said about that في الcheckpoint and the nurse لما تسأل المريض النيرس did you get your vaccine? We call this opportunistic health advice because the only way is to give the patient إنه هو زي ما بيقولوا بالعامية نصطاده، لأن هو ما حيجي بنفسه يعمل شغلة زي دي، هو بيجي عشان هو مريض ما بيجي عشان هو صحيح. الفكرة إحنا بنحافظ على الصحة وبنتابع نحافظ عليها، ما نبغى هذا المستوى ينزل. Pre-immunization counseling is هو مساعدة المريض إن هو يساعد نفسه، إن هو يأخذ القرار، إن هو يكون هو هذا الشخص المناسب للتطعيم المناسب في المكان المناسب. Assess for needed vaccines. يعني هل هو يحتاج التطعيم هذا فعلا ولا لا؟ هل هو في السبيسيفيك ايج جروب في الريكومندد ايج جروب ولا لا؟ سكرين فور كونترا انديكيشن اند بريكوشنز. لازم نشارك مع المريض ايش الاعراض الجانبيه، لانه هو حيكون اكيد خايف وشايل هم التطعيم هذا ايش هدفه، ايش ممكن يعمل لي complications. Educate the patient.
If I can interject you, Dr. Sana, let's open the subject now to talk about the contraindication for vaccines, because this is one of the issues that is very hot in our society.
Yes.
They said, no, I'm allergic, I should not take the vaccine. I had certain hypersensitive reaction with the previous vaccine, so I should not take it. So this is the perception. Let's open the floor now just to have this kind of discussion from your own experience.
Yeah, like hearing from the patients about their fear about contraindications, because some patients, they believe that they are asthmatic and they are a heavy smoker. That's why it's contraindicated for him, and they have fear of having flu vaccine.
Yes.
So this is, you wouldn't know about this unless you hear from them, like Dr. Ashraf mentioned, about listening to the patient, see what they are fear, why they are refusing the vaccine, this misconception about it. So it is helpful. And then you are the first one, if you are asthmatic, you are the first one, if you are a smoker, you are the first one who needs the flu vaccine. So contraindication is a thing that from my practice, I can see a lot of patients, they have misconception about contraindications.
Yeah, actually, there is no contraindications except severe hypersensitive reactions to the ingredients of the vaccine.
Yeah, now also they are talking about the egg allergy with influenza vaccine. So they just know the first sentence, but they don't know like the complete sentence. Like egg allergy is not a contraindication for the influenza vaccine, no matter what kind of egg allergy you have. So you still indicated to get the influenza vaccine, but it depends on the egg allergy that you had. If it was just a mild one, you can get it without supervision. But if it's a significant one, you can take it in a well-prepared healthcare center. So egg allergy is not a contraindication for influenza vaccine, and this is one of the most common questions that I got from my patient before giving the influenza vaccine.
I remember those days during the tents we did for the COVID-19. People who are at risk, we're still vaccinating them and keep them in a special rooms in order to observe them if they went into severe hypersensitive reactions. And we have all the equipments, all the tools, even, intensivists they were available in that particular unit just to intervene in case of hypersensitivity reactions. So to that level, we are trying to provide the patient with the benefits of the vaccine in spite of the hypersensitivity reaction. Dr. Brahman.
Yep, I think it's for contraindication, we have to think always about what type of vaccines will be given. For example, with the inactivated vaccine, usually there is no contraindication, apart of there is an allergy for the component of the vaccines. However, could be worried about the effect, the vaccine, if it's work or not. When this is special concern usually with those who is on chemotherapy or radiotherapy or on having on the chemotherapy cycle. So we have to be careful with those people that to avoid vaccinate them. The reason simply because of the vaccine couldn't be work, it was inactivated, and definitely the life attenuated, that will be risk to them. That's when they're on the cycle. But before it, this is the reason that we have to assist the cases in a time before they start the chemotherapy cycle. Again, for pregnancy, this is very important. There is some breast would be resistance for the pregnant to be vaccinated, even for inactivated, and so we have to be assist this and address it. And given the pregnant based on the risk assessment, however, we can delay the old life. We have to delay the life attenuated vaccine if she not vaccinated before the pregnancy. So after the pregnancy immediately. So. There's, for example, HIV patients, etc. It depends on the CD4 accounts. If we can't vaccinate, so it's less than 200, we have to wait for the viral load to be, 0, and the CD4 is high to give in the life attenuated. So we have to think always about the contraindication, that there is no contraindication for inactivated vaccine, except we are worried about the work of the vaccine. If there is any I would say chemotherapy or radiotherapy with life attenuated, we have to address if the patients or the who is coming to the clinic as for giving the life attenuated vaccine is a pregnant, HIV, and on cycles of chemotherapy or radiotherapy to be assessed carefully and to be given the vaccine even through the clinic or refer the cases for specialized to provide the vaccine carefully.
I have a question, please.
Yes, please.
So Dr. Muhammad, about how to overcome the concern of the patients to have multiple vaccines at the same sitting. Let's say flu vaccine and Shingrix at the same time, or Prevnar with flu vaccine. What do you think?
So yeah, if like two killed or inactive vaccines, there is no problems to give it together at the same time. I usually like when, for me, if the patient agreed to get the vaccine, I found like a very difficulty to bring him again for another one. So I would like to use the opportunity just to give him both. Like now, Shingrix and influenza.
Yes.
Majority of time, if he agreed now, I was worrying like if I will lose this patient. Yeah. If I give him the influenza vaccine, he will not get the Shingrix. But it's okay to give two inactive vaccines at the same time without any problem. So I always answer that question. Yes, we can do it. If you want, that's okay. We can give it to you, and no need to come back to get the vaccine. And how about the side effects? All the mentioned side effects that was reported, it's almost the same, even if you get the two killed vaccine. And there is no any contraindication between the Shingrix and the influenza vaccine. So I always give them together, like with our patients.
Sometimes they have the fear of post-injection,
Yes.
fever,
Yeah.
pain. I was like, okay, so you would use paracetamol, and this is the prescription. If this is the only concern, so we can overcome it. So I think having this specifically with elderly, my personal way of dealing with them, I used to prescribe paracetamol 500 twice a day for 3 days, just to overcome this fear.
And the other thing, we're giving children many doses. في عيادة الأطفال إحنا بنعطيه كذا جرعة.
Exactly. Exactly.
So why not? Why you are afraid? Why you are adult يعني?
Yes.
Absolutely. Okay, because of the sake of the time, we move now to the most important part, that is the talk of the town today, is the Shingrix. And I would like to ask Dr. Asim to tell us, can you tell us more about the shingles risk in older patients?
Sure. So let's go with the numbers. Unfortunately, we don't have number here, local number for the need. However, as we see, the number and the incidence rate will be higher once we get older in all those countries. And I bet in Saudi Arabia we have the same issue. The other problem is not only about the incidence of infection, it's the incidence of post-therapeutic neuralgia. And as we see here, I mean, it depends also about the severity of the attack and the coincidence of having other medical problems that would make the infection more. So unfortunately, there is an increase. The rate of the infection increased with aging. I think I did illustrate this about our immune system, but as we see here, I mean, our cellular immunity and the response of the varicella at the beginning, once we have chickenpox, the immune system get, ready and having learned about this infection, antibodies will be generated, and then if there is another exposure, the system will be like more ready about it, about having this kind of infection. Unfortunately, in case of having medications that lower our immunity or disease that cause our immune system down, the risk will be higher. Above age of 50, this is where we are talking about the risk will be much higher, and we can see that the national campaign about having the Shingrix at age of 50, 2 doses, that would protect you. And I used to explain not only the disease. I used to explain the patient the symptoms, and it's not about the attack itself. Unfortunately, the pain is something, it would bother the patient the most. It will affect his sleeping, it would affect his day. Unfortunately, with long-standing problem with sleeping, the patient might develop cognitive impairment, so the consequences is huge. So starting that discussion with the patient would facilitate a lot of things, and the patient would accept the idea of having the vaccine. Here, with the chronic diseases, the risk the risk of having the infection with the chronic diseases, as we see here with COVID infection, 15 to 20% increased risk. And for sure, we don't know exactly if we had, some of us, they don't have a documentation of having COVID, but I bet most of us had COVID, and the response of that to that infection is vary from one to another. However, the risk will be higher. With malignancy, our immune system will be affected. HIV definitely 3.2 times increased risk. With autoimmune disease and the need of monoclonal antibodies, that would decrease our immune system. Steroid use, chronic renal disease, we have 30%, and my colleague here mentioned about the transplantations, and the risk will be higher. Diabetes, and as we know that the prevalence of diabetes here in Saudi is huge number of patients, then the risk will be high. So as we see here, definitely we need to go with the vaccine, and we need to support the public awareness campaign that our government is doing currently. On the other hand, it's free of charge. So it is all what the patient needs to visit the primary healthcare center to have the vaccine.
Dr. Majid, what other conditions might add to the burden of shingles? What are the risk factors?
Thank you, Dr. Ashraf, for your question. I think it's, as explained by colleagues, with immunosenescence and effects of the chronic disease in general, definitely this will make a burden into the immune system and make the risk of vaccine-preventable disease could be developed. And one of that, actually, the herpes zoster. We can see this data that we can share with you. There is increase of the herpes zoster of some of the specific group of patients. It reached to 23% with the depression, 24% increase with asthmatic patient and diabetes patients, almost 30% of increase with those having chronic kidney disease, and with cardiovascular disease, it reached to the 35%. So that's explain how those people who are having that I would say chronic disease would be having a high risk of developing herpes zoster. And this is the reason we have to be consider them as a priority for any vaccine program that we are expect to do. Again, with the recurrence, even it was seen higher among with those underlying condition, and even with those younger group to the 50 years, they found they are higher than other groups. They could develop the herpes zoster again because of the underlying conditions. So this is all these studies explain that we have to go those above 18 years above and having the underlying disease, they have to be counseling about the importance to receive the vaccine. Again, this is the increase of the cerebrovascular, cardiovascular accidents, including the stroke, and that's was very noticed among those having to have herpes zoster, especially with after the attack, in a week, so they can develop herpes zoster again once they have having the cerebrovascular accidents. So with other studies, with the meta-analysis has been done indicating also the increase of those people having any risk of underlying conditions such as the cardiovascular disease, they will develop the herpes zoster, and they could have the recurrence rate high in comparison to the other groups. So the risk has been raised. It was reported between 34% to a double and 3 to 25 times risk. So that's definitely a message that we have to be given for those underlying disease. We have to be target them and giving the priority for vaccination for the herpes zoster.
Thank you, Dr. Majid. Dr. Muhammad, regarding what is the worst complication ever that the patient with shingles could be exposed to?
Okay, so let's talk first about the most common complications in post-herpes zoster, which is post-herpetic neuralgia. So if we talked about the post-herpetic neuralgia, it's like overall it's about 10 to 15% of any herpes zoster, they will suffer from post-herpetic neuralgia. But look at this percentage after age of 60. After age of 60 is gonna be 50%. People after herpes zoster, they will suffer from post-herpetic neuralgia. And the pain is very severe and it's very bad, and it will like disturb the whole daily activity for this patient. They will come to you, they don't know if they are sitting or they are standing, they are like moving because the pain is very bad, and it's very disturbing the whole life. So, and now I noticed like majority of people, like because of the pain, they asked me in the clinic, am I gonna get the herpes zoster again? I'm like, unfortunately, yes, you're at risk. So how can I prevent it? I'm like, you get the vaccine. So I can get the vaccine after the herpes zoster? Answer is yes. When can I get it? I'm like, majority of studies, we can get it like after 2 months from the acute infection. But in the CDC, they say they are safe in the first year of the acute onset. So I can get it in 2 months, yes. I'm gonna advise every person in my family to get it because I don't want anyone to suffer from that pain. So they know that the pain is very bad. So now they are like serving to bring more patients to you. Like, can I bring my family to you? I'm like, yes, please do it. So she will explain to them even better than me, because she will tell them what is the real pain is, what is the suffering, how it was, with the person that they trust is from their family. So now that what I'm noticing nowadays in my clinic, let's see patients like immunocompromised when they got shingles. Like they come with a very atypical presentations. You don't know what's going on. They come with like encephalitis picture.
Yes.
You look at their skin, you didn't find anything. And you did this, the lumbar puncture, and in the DNA testing of the CSF, you find herpes zoster.
Yes.
I'm like, what? Yeah, that's a presentation immunocompromised. They present with a very atypical, generalized rash all over. And at the end, it's gonna be zoster, hepatitis, pneumonitis. They just like present at the first time with that. Some people, they present with burning, like neuralgia pain without lesions. They would tell you like this pain is whole, like this area is all burning, and they are immunocompromised. So you start the medication, and days later you will notice that the rashes start to appear. So complications more common in immunocompromised patient, and also it is also common with the patients with comorbidities. Look at the lowest picture, the patient with herpes zoster ophthalmicus. Those people, they can lose their eyes. Those people, they can be blind if you didn't like pick them early, and you didn't give them as early as you can from the antiviral. So we have to act very fast because antiviral is noticed to decrease the activity of the disease, noticed also to decrease the complication of the disease, also noticed to prevent or decrease the risk of post-herpetic neuralgia. So 3 things, the main benefits of initiating antiviral as soon as possible: preventing complications, dissemination, and complication with post-herpetic neuralgia. Look at the pain. So if we look at the acute pain and the chronic pain, look at the herpes zoster. Where is it? It's like close to the labor pain. Can you imagine? It's very bad. In the acute pain, if you compare it with other acute pain conditions, look at the post-herpetic neuralgia, having the same thing. It's very close to the musculoskeletal pain, to the arthritis, even worse than the arthritis pain. So and on the other graph, it really disturbed the physical and the daily activity of the patients. So you can make this patient is like totally inactive and psychologically inactive due to a post-herpetic neuralgia or acute onset neuralgia due to acute herpes zoster. And this is just like a kind of a disseminated more than one dermatomes. And as we mentioned, more complication, post-herpetic neuralgia is very common on those kind of patients, and an immunocompromise itself can make them very prone to a complication of herpes zoster infection.
Okay, Dr. Asena, how we can protect those people who are at risk of having shingles?
Again and again and again. The only way is to protect our population is through vaccinating them, especially those at the recommended age. This is a good example of how to overcome the immunosenescence, the adjuvant system, that what happened here in the recombinant varicella zoster vaccines. They're getting that glycoprotein antigen of the virus and added to it an adjuvant system to increase the impact or enhance the good response of the immune systems. Again, the justification why they're using that recombinant system than the adjuvant system, just to address the population-specific challenges and restore a durable immune systems. I love that regarding this graph, I want to really concentrate in why they use that population. ليش أخذوا ال 50؟ هي دراسة معمولة عشان هذا اللي هو الهيربيز زوستر فاكسينز، أخذوا ال 50 بلس وال 70 بلس، وطبعا في ستادي جروب البوبوليشن جروبس. لاحظوا معايا في ال 50 بلس في النهاية الافيكاسي ريت كان 97% في البوبوليشن جروب اللي هم كانوا 50 بلس، لكن في ال 70 كانت 91%. الاثنين كويسة، بس الأفضل لما نبدأ نطعمهم على ال 50. عشان كده we adopted and we started to vaccinate people at 50 بلس، يعني من ال 50 وأكثر. Can recombinant zoster vaccine still protect those with comorbid conditions? Can I share that slide with my colleague because he is concerned regarding that point? Doctor, would you please just to take a little bit and talk regarding this slide?
The previous one.
الكوموربيد اللي هو الهربس زوستر vaccines against اللي هو with medical conditions.
Yes, so with the herpes zoster, like the vaccines, as we said, is going to decrease the complications, it's going to decrease the post-herpetic neuralgia, and also it's going to decrease the complications that happen with patients with comorbidities. And as we mentioned, like if we just like put the stroke, it was very made clear that herpes zoster vaccine, like the recombinant vaccine, it will decrease the risk of stroke formation, like ischemic or hemorrhagic. Now, there was a study I was like reading about it. It was published in April 2023 in Open Forum Infectious Disease by a group in the University of Buffalo. They were doing a retrospective study about 2 million people and just screening what happened, like how many percentage of the patient after getting the acute zoster developing MI, and they were like 0.3% in 30 days.
Yes.
So they were like, we need more studies to link between the acute infection with acute coronary syndrome, because we already linked it to the cerebrovascular accident. Can we link it with acute MI? And that's many ongoing studies. They are working to find if there is any link between the herpes zoster infection and MI, because the main reason was to do a cerebral angiitis, like a kind of vasculitis to the cerebral vessels. Is that also can happen with coronary vessels? That's what we are gonna see in the next few years, inshallah, and to see if there is any positive or negative impact.
What can healthcare provider do to overcome vaccine hesitancy? Ruling with or dealing with uncertainty. The patient is not sure whether to go forward or backward. What we can do for them? أنا أعتقد هذا الموضوع يتحمل عدة زوايا. أولها إحنا كفيزيشنز قد إيش عندنا المعرفة، قد إيش عندنا الرغبة إن إحنا نبغى نثقف المريض ونزيد الأويرنس. Education. We need to keep educating our patients, increasing the awareness of our patients. For us as a physician, بالنسبة للpatients, he has the right to choose whether he wanted to get vaccinated or not. هو له كامل الأحقية بعد ما أنا أشرح له الإيجابيات، السلبيات، الريسك، الريكومنديشنز، إيش اللي معمول هنا في البلد. هو له كامل الأحقية إنه هو يختار because we are respecting the patient autonomy with dignity. بعد كده الانفايرمنت والسوشيال ميديا، الامباكت اوف environment. بالنسبة للنقطة هذه الهيزيتنسي I think for us as a يعني برايم اللي هو الهيلث كير بروفايدرز احنا بنلاحظها في جميع مراحل لقاء المريض، انه مو بس حتى في الفاكسينيشن، في اشياء كثيره المريض ممكن يكون متردد. اللي يدفع المريض انه يرفض او يوافق على التطعيم هو احنا. اذا احنا كنا مؤمنين بالتطعيم هذا مهم وعارفين انه هو يحتاجه، تاكد هو حتتغير افكاره، حتتغير مشاعره، حتتغير سلوكياته. So we work in that 3C models: confidence, convenience, and competencies. The definition of vaccine hesitancy: delaying in acceptance or refusal of vaccine despite the availability of vaccine services. That's what happened right now. بالنسبة للشنغريكس vaccine هذا اللي بيحصل حاليا، رفض شديد بالرغم من توفر الفاكسين، توفر الخدمات، المرضى رافضين. تتوقعوا ليش؟ هذا الجزء هذا يقع على عاتق من؟ إنه ما زال المرضى يرفضوا التطعيم هذا. Us. We are still not educating our patients. We are not increasing our awareness. المريض دائما يجي هو شايل هم الcomplications. Okay, go back with him and discuss with him. كلموا على المرض، كلموا على الريسك فاكتورز، كلموا على مضاعفات المرض، زود خبرته ومعرفته عن المرض نفسه، بعد كده سيبه. أحيانا زراعة الشك في قلب المريض مفيدة. كل مرة في الكونسلتيشن أديه معلومة صغيرة وخليه يروح البيت يفكر بينه وبين نفسه، يا ترى آخذه، يا ترى ينفعني، طب هو ممكن يعمل. كل مرة حيجي ياخذ منك معلومة عشان هو يبغى يبني كلمة ايوه انا موافق، هو ما حيقولها على طول، حياخذ وقت. عشان كده في كل مرة انا بديه دوز صغيرة معليش حياخذ وقت بس حفضل اعطيه. هذا معناته احنا لازم نكون صبورين اكثر مع المريض ونفضل نعطيه كل مرة جرعات صغيرة. أنا أسميها الشك، اللي هو نظام رمي الشك أو الداوت في قلب المريض. ترى أنت ممكن يجيك المرض في لحظة ما إذا ما طعمت، لأنه أنت من الريكومندد جروب ايج جروبس. البرسبشن اوف ريسك كان كرييت فاكسين هيزيتنسي. ذيس وات اي مينت، اللي هو نظام اللي هو ريزنج، اللي هو انه انا افضل اخوفه ثريت انه في شيء يهدد حياتك في اللحظه دي ولازم تاخذ قرار. If people perceive high level of risk of disease, they will be more likely to vaccinate. But if they perceive high level of risk of vaccination, they will become less likely to vaccinate. Did you get my point? هو بيسمع التطعيم بس ما هو سامع عن المرض، فأنا حشتغل على حتة المرض. How can healthcare provider communicate effectively with the public about vaccine to reduce hesitancies? What did you think? How we can reduce hesitancy? We're dealing with uncertain peoples. جاك المريض وهو ما يبغى، متردد، أو هو يبغى بس متردد خايف. What did you think? Open-ended questions. افتح المجال للمريض عشان يبين، يقول لك مخاوفه، يقول لك هو خايف من ايش، يقول لك مشاعره، يقول لك هو ايش فكره، ايش توقعاته عن المرض. لانه الطريقه الوحيده اللي انت ممكن تتكلم فيها مع المريض انه انا افهم هو خايف من ايش. طب هو خايف ليش؟ ولا لا انا كيف حتكلم مع انسان انا ماني عارفه خايف ليش؟ هو خايف بس. طب انت خايف ليش؟ عشان انا اقدر اصحح له الغلط، المسكونسبشنز، واضيف له الصح، الاشياء اللي ممكن هو ياخذ فيها قرار صحيح. Educate about vaccines with clear, complete and accurate message. Can trust and engage. I cannot see والله at this levels. Can trust and engage. والله I cannot see that stage. But I think communicate and up-to-date information. Address the misconceptions. Use patient-friendly language. لغته اللي هو يفهمها. And don't use jargons. يعني مرضى كثير عندنا يعني أنا دائما أقولها باللغة العامية، كل مريض متفصل تفصيل. المرضى اللي هم تحس عندهم ميول ديني يكلموا بهذا المنطلق، ولا تلقوا بأيديكم إلى التهلكة، ولا الآية تقول ولا تلقوا بأيديكم إلى التهلكة. أتمنى تكون الآية صحيحة أنا قلتها. ترى الحماية هذه سنة إلهية موجودة في القرآن، وحتى الرسول فيما معنى الحديث إنه كان لما يكون في قرية في طاعون يقول لهم لا تدخلوها أو ابعدوا عنها. فسنة فموضوع البروتكشن والفاكسين هذا شيء كوني إلهي. How we can increase the vaccine acceptance among the public. الآن أنت في العيادة وكلمتي المريض، مريض لمريض، one person to person. الآن في البابليكس أنت متحدث بتكلم البابليك، إيش حتقول لهم؟ كيف حترفع الأويرنس في البابليك؟ إيش حنستخدم الطريقة القوية جدا اللي إحنا الآن بنستخدمها للبابليكس؟ سوشيال ميديا. excellent. الميديا أنا قلتها قبل وارجع أقولها. If we did not lead our patient, they will get led by others. لو إحنا ما قدناهم حيقودهم الآخرين، سواء كانوا influencer، social media، الرسائل اللي بتيجي على الواتس راح يقادوا بها. We have that rules. We have this basic thing.
So they cannot bridge your trust to the patient. It is important. I mean, bridging for the confidence. But look to our clinic. So busy clinics. So
لما حضرتك دكتور تكون في العيادة الآن دكتور تو بيشنتس، بس الآن أنت في البابليكس مو بالضرورة تعملها في الكلينكس، ممكن تعملها في الفري تايمز تبعك. لو عندكم مثلا قناة معينة للأدفيرتايزنج، لما تعمل محاضرات برا العيادة عندك في أوقات فاضي فيها تعمل محاضرات برا العيادة، أو في تجمع معين عندك مثلا، ممكن تكلمهم في البداية، يعني تبدأ ستيب باي ستيب، بعد كده تستخدم السوشيال ميديا.
I suggest one thing, maybe this is it's clicked to my mind. We have so many cafes around the city.
ممكن هذه
We
طريقة.
could, I mean, sit down. I mean, I can just go and talk with the people, the attendee over there, and spread the idea. I will be there on once a day from 6 to 8.
This is a good idea.
This is an idea.
This is a good idea. What did you think بالنسبة للباقين؟ إيش تتوقعوا أفكار جيدة إحنا ممكن نوسع فيها فكرة قبول الناس لموضوع التطعيم حق الشنغريكس أو كل التطعيمات بصفة عامة الأدلت vaccinations. EV is another kind. الآن لو لاحظتوا في قنوات الام بي سي إذا بتلاحظوا بعض القنوات التطعيم حق الشنغريكس بيتعرض ما بين الفينة والأخرى بيتعرض هذا التطعيم. فهذه طريقة جدا جيدة في إنه يعني attracting the attention of patients. أنت فجأة بتتفرج مثلا مسلسل ولا إعلان فجأة تلاقي الإعلان تبع التطعيم موجود.
I think the journey of patients with herpes zoster goes through the 3 levels of prevention: primary, secondary, and tertiary. So we start by health promotion, educating all the public and all the people around, and even the physicians. And then we go for specific protections where we have to spot those people in the community at risk. I identify them and keep them as a category of a special concern and a special need for us for special services. And then early detection of the disease in early stage, so we can tackle it before it gets into complication. And once the disease happens, we have to treat it properly without, because it's usually undertreated, mistreated, misdiagnosed, underdiagnosed, and so forth. And then the last stage, once the complication happens, which is the post-herpetic neuralgia, it has to be treated appropriately in timely manner, rather than getting into the complication of encephalitis, pneumonitis, and even the devastating consequences of post-herpetic neuralgia that compromise the quality of life. So this is a spectrum that we could think about it. So we have a role on each step of them. So we have to be broadly minded and not only treat patients or anticipate the patient will come. No, we have to get out of where we are and look into the whole picture in total.
Okay. The ideal clinical profile, acceptable safety profile, positive demonstrated risk-benefit profile, immunogenic with validated correlate of protection, demonstrated efficacy, demonstrated real-world benefits. Can I share this one with my colleagues so that to explain more in that pictures?
Very important to discuss it with the patients or vaccinate person when we could release or could share with some of the real live data. We could, simply can explain to them that we had some of studies and those vaccinated, they never been, having the infection, and this is a worldwide study and published in the best medical journal. So this is sometimes now it can be also people they start scientifically ask, and this is I would say also our colleagues as physicians, healthcare workers, the hospital, they ask these questions especially for the flu during the campaign. So we can share with some of the real data that could be helped, and people also worried about the safety profile. So the one that we have, we could also share it with colleagues that the risk would be very low. However, we can share the risk. I would say, for example, for COVID-19, for the mRNA vaccines, I could mention there is a possibilities of the very rare adverse events like myocarditis, for example. So I don't want to, say nothing could be happening, but I would say we have a high safe vaccines based on the best studies that reported the safety profile. In addition to them, outweigh to the risk of to have the disease, as mentioned by Dr. Ashraf before. So which one is that we could either get the disease and have the complication consequences, or getting the vaccines to prevent the disease. But I'm thinking about the rare side effects that could be happened or not. So this is one of the things that we could share the data for the colleagues. I think the number of efficacy, if you remember that when they introduced COVID-19 2 years ago, and they mentioned what is the efficacy of the vaccines for each one. And these numbers, I think, lead people. If you remember, Specific vaccines have a 94.5. I think you remember that number still, and others 95. And it was this 0.5. It was a huge discussion why this better than the other, and the other vaccine or reached the 83%. So that's when we shared with people. That's also can convince them, especially when you have a pandemic or we have, you are worried about that the specific disease could be paralyze your health system. So you want to introduce these such interventions to help to increase the herd immunity. So simply sharing of real data, yes, it's very important. I think for the patient, we can, in a simple way, we can explain to them.
Yes, thank you, Dr. Then, as a part of building the trust with our patients, we need really to explain to the patients the importance of vaccine and the side effect of vaccine. Some vaccine common side effect we can see, anaphylaxis, 0.2 in 10 cases per 1 million doses. Oral polio vaccine, paralysis, طبعا very rare side effect, very, very rare, but we need really to mention it to the patients. Here is few examples. Weighing the benefit and risk to the patients. I think mentioned before by Dr. Ashraf, we need to really to weigh the benefit and risk. هل هذا المريض فعلا يحتاج التطعيم ولا ما يحتاجه؟ حيستفيد لو أخذ التطعيم ولا ما؟ هذه الأشياء نحتاج نوزنها مع المريض. Saying the advantage and disadvantage of vaccine, it's very important. Anyone want to add anything in that slides? Dr. Ashraf, do you want to add any?
No, nothing at all, but I think everyone required to have the vaccine.
Yes.
And even if we weigh risk and benefit, definitely the benefits outweigh the risk all the time. So this is a message for all the populations to come and receive the vaccination without hesitations.
Yes. Here is few success story. أكيد قصص النجاح. Yes, تفضل.
طيب اوكي.
قصص النجاح دائما تلهمنا لما نشوف مدن اخرى ودول اخرى قد ايش الفاكسينز عمل لها ريدكشن في نمبر اوف ديزيز، في نمبر اوف هوسبيتاليزيشن، عملت كامبين لديزيز واختفت امراض كثيره. احنا حاليا الان زمان كنا بنعمل حملات عشان تطعيمات مثلا عشان الاطفال، تطعيمات الجديري، الان ما عدنا نشوف هذه الحالات بسبب انه الكامبين المستمر والتوعيه المستمره من الناس. نفس الشيء الصور هذه بتوضح قصص نجاح في بعض الدول قد ايش انه في فاكسين معين نجح في، خلينا نقول، في الإراديكيشن اوف سام ديزيزز. احنا اكيد نبغى نكون في مصاف هذه الدول في الإراديكيشن اوف سام كومن اللي هو الانفكشوس ديزيز والامراض اللي ممكن تنقرض تماما عن طريق التطعيمات. في مكسيكو الدياريال هوسبيتاليزيشنز وبين قوسين اللي هو الديث prevented by rotavirus 11,000 اتطعموا، من اللي اتطعموا بس 600 اللي هم طبعا حصل لهم الديث. في البرازيل 69,000 من اللي اتطعموا، 640 اللي طبعا توفوا. في استراليا ولا حالة وفاة، 00 و77 أكثر من 77,000 اتطعموا اللي هو طبعا ريغاردن اللي هو روتا فيروس. وهذا بالنسبة لهم حقيقة نجاح، يعني نجاح واضح إنه ما في ولا حالة ماتت بعد التطعيم. COVID-19 vaccination prevented around 24 million infections in England. أنا برضو حسيب السلايد هذا دكتور أشرف صراحة to elaborate in it more. What did you think دكتور أشرف؟ حسيب السلايد هذا لحضرتك to elaborate in it more.
معلش ما سمعت.
حسيب السلايد هذه لحضرتك to elaborate on it more.
For what? For the COVID-19 vaccination prevented around
COVID pandemic.
Yeah, of course. It goes without saying the benefits was quite obvious that we have, alhamdulillah, with all the restrictions and the mass vaccination that we had in our nation, in our country, we have sustained, the different waves of the COVID with the minimal mortalities and morbidities, and we have secured an example that can be proudly presented to all nations and all healthcare system that we had a very successful model of managing the pandemic successfully with a very limited consequences. So I think because of the vaccination, it has a very big role.
Yes.
Because of the strong decisions to mandate all the shutting downs, all the activities. So we had two systems in the globe: system that care for the human being and system that care for the economy. Alhamdulillah, caring for the human being as a kingdom of Saudi Arabia, alhamdulillah, we have sustained this kind of devastating crisis, and we went to all the safe shore with no time, alhamdulillah. I think vaccination played a very important role in this. So thank you so much for everyone. And now we will like to open the floor for the questions. We have the question from the audience and we have the virtually attending colleagues, so we can receive some of them. Please go ahead, Doctor.
Yeah, I just want to ask if a patient coming to you and he doesn't know what kind of vaccines he took before, and probably it ends up that he's taking the 2 vaccines of Zoster, can you give him a third one?
The recommended is 2 doses, the first dose, and 2 months to 6 months, the second dose.
Right.
But
If he forgot or he doesn't know what he took, in the past,
yeah.
so can you give him a third dose of
You give a booster dose.
So now, they introduced the herb zoster actually since a couple of months, and by law, that it's now they mandate everyone take any vaccine in the kingdom to be registered and documented in the national vaccination registration system. So this is very important. We'll be surprised if someone not document this. So there is no, I would say, they suppose that there is no missing, as we consider that documentation as one of the best, if you remember the 7 rights, one of that, the documentation. So this is something that we have to think about it. However, if someone received that, we have to ask the patients if he received the doses. We could ask when he received the doses, if it's confirmed. If it's confirmed that they only received 1 dose, he or she could receive another dose, and this is considered as inactivated. So there is no risk. So this is not, I would say, an open message for anyone who shouldn't, to revise the documentation. I would say if I'm in these positions, I would raise the SRS, which is this is for investigation. Why not documented the vaccine? So, but for the protection we can provide, the patient can give the vaccine if he already more than 2 months of the receiving the first one. Okay, so it's considered as a catch-up.
Scientifically speaking, can he take it?
Scientifically, there is, to be honest, there is no, I would say, any indications or any literatures indicate that we have to provide inactive vaccines as anyone that would. So this is the reason we have documentations. But it depends on the high risk. If the patient is at high risk to getting the disease and he or she is not having any evidence and not sure to receive the vaccine, he or could take the second dose, okay, or the third dose, for example, in hepatitis B.
Okay, any other
But this is again, we have to be careful. Documentation is very important, essential, and consider as, I would say, SRS, it's a quality against of the work of the medical practice and reach to the legality for the practice.
Dr. Muhammad, تفضل.
I just wonder regarding we have the hemorrhagic, get the benefit with the hemorrhagic or ischemic strokes. Is there anything in the research regarding the diabetic foot, which is the most important in our clinic? Is there any in the research as well will help that this vaccination will help in that aspect? And my last comment, I love to start like we are here in the family medicine domain. I think that you are the leaders for the medicine all over the country. I think we need, my idea for, I try to start, the cafe talk, which we can talk regarding diabetes, orthopedics, vaccination, or obesity. We can run an obesity club through maybe in one cafe, and that could be connected to other cafes. So we will have as well a virtual audience in the back of that talk. Thank you.
I will answer the first part of the question. So I'm not aware about like any studies about the diabetic foot and or diabetic foot infection and the herpes zoster vaccine. But if we think about the relationship between the stroke and the herpes zoster, it's related to vasculitis. So, and if we think about like the diabetic foot with a zoster, you know, maybe there is a relation if there is just like a neuropathic pain, but usually the neuropathic pain, it will take some time and it goes away on its own. So I don't think there is like, I'm trying to think about if there is any pathophysiology can link those two together. But I'm not aware if there is any studies yet.
I think once the patient reaches to the level of having diabetic foot, he would reach to the point of having complications. So he will be at risk more than others of having the, infection by itself. So totally we would recommend, maybe it won't be for the diabetic foot prevention, but it will be for the patient health as long that it's a part of the complication of the disease.
Regarding your recommendation, Dr. Mohammed, regarding the coffee talk, so I think we can convert the vaccine talk to the coffee talk next time, sponsorship with the GSK. But again, we have to remember that we have to target a certain population above the age of 50 for Shingrix, for example, and for other vaccinations. Those who are residing in the coffee shop, they are young populations. So they could be the way to disseminate this kind of information for their parents, for their elderly patients at home. This could be one of the modalities, but again, we have to think where are those people who are located. For example, they are in the malls or they are in the haram doing Umrah and they are in certain mass gathering where we find this kind of populations available, so we can deliver this kind of messages to them at that particular points of care.
But there is no harm for giving the youngest, right?
No harm?
Yes.
There is no harm to give the vaccine to the younger guys.
To the younger with certain comorbidities, but usually the recommendation is 50 years and above for the Shingrix. But those, we can go below 50 if there is immune compromised patients below the 50. Yeah. Any other questions from the audience here? Yes, please, Doctora.
السلام عليكم. سعيدة جدا بتواجدي معكم اليوم. تعريفا بنفسي، أنا دينا منياوي، سفيرة التوعية الصحية بالإمارات. جزئية جدا نوهت عليها دكتورة سناء على موضوع الأويرنس. موضوع الأويرنس للأسف صار عندنا فكرة الناس اللي بتتكلم بمعلومات مغلوطة في السوشيال ميديا، ما بتكون أساسا فيزيشن، ما بتكون دكاترة، ما بيكونوا ليهم علاقة أساسا بالمجال الصحي، وبتعطي معلومات خطأ. فواجبنا إحنا كأطباء نقدر من حسابات السوشيال ميديا، من الإيفنتات اللي بتنعمل في أي مكان، إن إحنا نحسن ونصلح المعلومات اللي بتنتشر للناس بطريقة جدا خطأ يعني. فأنا من الشخصيات اللي فاتحة حساباتي في السوشيال ميديا وبتكلم في مجالات كتير، ومن قبل سبق لي حضرت مع دكتور نزار باهبري في أحد المقابلات وكنا بنتكلم على هذه الجزئية. فالجزئية اللي نوهت عليها دكتورة سناء جدا أنا من المؤيدين ومن الداعمين صراحة. أول حاجة دولتي أنا لازم أدعمها في السعودية قبل الإمارات طبعا. فجدا حابة أن احنا نفعل موضوع السوشيال ميديا في التوعية الصحية.
شكرا دكتورة. يعني هذه نقطة مهمة جدا، وإحنا عارفين أنه مواقع التواصل الاجتماعي مليئة بالمعلومات المغلوطة اللي يروج لها ناس خارج الاختصاص، واعتقد هي الآن احنا تبنيناها كجمعية السعودية لطب الأسرة والمجتمع أن نطلع عندنا لجنة لمراقبة مواقع التواصل الاجتماعي من الناحية العلمية، وإذا كان في أي معلومة مغلوطة يعني بنصدر بيان صحفي أو بيان في كل السوشيال ميديا بنشير إلى هذه المقولة ونضع يعني المعلومة الصحيحة ونؤكدها من خلال الجمعيات. وأعتقد هذا هو دور الجمعيات العلمية scientific societies في مراقبة المعلومات في الأوساط في الوساط في السوشيال ميديا، وبالتالي كلنا دور استباقي واحترازي في حد من نشر هذه المعلومات المغلوطة، لأنه في النهاية ما نبغى نوصل نضيع وقتنا كأطباء أمام مريض مقتنع بمعلومة سمعها وبياخذ منا وقت وجهد حتى نغير المفهومة هذه. ودائما زي ما بيقولوا المعلومة المغلوطة تنتشر بسرعة أكثر من المعلومة الحقيقية الصحيحة المفندة الموثقة.
May I add one point? I think we need to be on the proactive mode instead of having to be on defensive zone. This is what we are dealing. I mean, like whenever we have wrong informations, medical informations, we used to be like then defensive mode, and then I mean like a lot of talk about whatever being said. But I think I agree with you regarding having a proactive initiatives regarding those kind of things. And instead of having wrong informations, we would reach to the population faster. With the new way, I mean, like, unfortunately, we are physicians, like, we need, I mean, like, a lot of time to express our thoughts. We need to get to the language of public, short, I mean, very short videos, focused to the point. I think this is what they are looking for.
Yeah. Okay, I think because of the short of time and we are reaching to the end of our scientific event, on your behalf, ladies and gentlemen, and the colleagues, I would like to thank our faculty guest contributor for this wonderful session, Dr. Majid Al-Thaqafi, Dr. Sana Barnawi, and Dr. Muhammad Sananoudi, and Dr. Asim Al-Shambari. Special thanks for all of them for their wonderful contribution for the success of this event and the rich information they have disseminated. I was privileged to moderate this session, and I truly can tell you I enjoyed all what has been said, and I learned a lot because it's a learning experience for all of us. And I hope that you enjoyed the way I enjoyed, and I wish our colleagues who are attending with us virtually, they attain a good amount of information that we can carry along with us to our practice tomorrow, inshallah, with a different mentality, different perspective. And I would like to mention that adult vaccination is still undercovered, and there is a lot, the coverage of adult vaccination is below the optimal. To my knowledge, I don't know, my colleagues, they can correct me, it's about 37 to 40 to 45% maximum that we have achieved for adult vaccination, unlike the pediatric vaccination, which we reached 90, 95 plus. So there is a lot of responsibility shouldered on all of us as a physician. We have to disseminate the information that vaccines are safe, it's mandated, it saves lives, and it is efficacious, and at the same time it's safe. So we have to disseminate this information and equip ourselves and our colleagues in primary care and elsewhere with all the skills and the knowledge and the competency and the courage and the confidence to tackle this kind of hesitancy. With this, I would like to thank you all for attendance, and I would like to extend my thanks to الجمعية السعودية لطب الأسرة والمجتمع. Special thanks for GSK for sponsoring this event, and special thanks for the organizer ملتقى الخبرات لتنظيم المعارض والمؤتمرات. Till we see you again in another sessions of Vaccine Talk. I wish you all the best and wish you good practice. في أمان الله. Mike, okay. So please don't forget to scan the code for the post-test, and you will be receiving the answer, inshallah, on your email. Thank you so much, and we will have the lunch together next door. Thank you.